Yes, sir, we are live now.
मुझे दिख तो नहीं रहा है सेशन लाइव होता हुआ यूट्यूब पे। अच्छा, हो गया। ठीक है। हाय स्टूडेंट्स, गुड इवनिंग। दिस इज डॉक्टर प्रवीण त्रिपाठी एंड वी विल बी स्टार्टिंग विद द INI-CET रिकॉल सेशन नाउ। सो थोड़ा सा प्लीज गिव मी सम फीडबैक। कैसा रहा पेपर? हाउ वाज द पेपर? हाउ वाज द एग्जाम? सो from whatever little I have been able to gather, the PYQs were there, but they were twisted quite a bit by the examiners. So is that correct? Is that statement correct? That even the older questions which were there in the paper, they were twisted. They were not very easy, not straightforward. All right. So I'm yet to talk to all the faculties. As far as my subject is concerned, uh, some of the questions were very straightforward. There was one difficult question, which is a new question. They have not asked a question on DMD till now, but आई थिंक बहुत सारे सब्जेक्ट्स के बारे में भी ओपिनियन बचा हुआ है. सो यू गाइस आर सेइंग, so some of you are saying difficult, some are saying easy, difficult with lots of twists. Chalo, I think it's too premature to make a comment. In the last INI-CET, everybody came out of the examination hall feeling very happy. That was a very simple paper. It turned out to be a pretty difficult one. The cutoff actually plummeted. So I think after this exam, it is not wise to make any kind of predictions or any kind of judgment so soon. Let us wait for all the teachers to see the question. Let us see how many of them were repeats, how many of them were PYQs, twisted PYQs, how many of them were difficult. उसके बाद ही we'll make some kind of opinion. चलो, let's start. I'll start with the psychiatry subject. All right. So this was the first question. This is a straightforward question. A patient on an antipsychotic, haloperidol, and he's presenting with raised levels of CPK, fever, and autonomic instability. So diagnosis is clearly NMS, neuroleptic malignant syndrome. Neuroleptic malignant syndrome. Somebody is asking, sir, how to prepare for such googlies? See, uh, they are not googlies. If we just study superficially and with the hope that everything would come from the PYQs or last year subjects, even if they ask questions from the previous year topics, they are going vertically deeper. They're asking deeper question. Look at this question, right? Even in this question, this is a PYQ only. But now they are making it USMLE type. What is the next best step in the management, right? So a bit of deeper understanding would be required, and this is true for INI-CET as well as NEET PG. तो थोड़े से concepts building पे focus करना ही है. It is not optional. Anyways, this is NMS, and what is the treatment of NMS? You have to stop the antipsychotic, and the drug of choice for NMS is dantrolene. So A is the answer. Let me know if there is any mistake in the recall that I have collected. Second, again, a very standard question. A patient is coming to you with sudden loss of vision, a neurological deficit. There is no abnormal finding. And then there is the history of labile indifference, lack of concern with the symptom. And then they have also given history of a loss of family member in an accident. So everything goes towards convergent disorder. This is a standard question. Labile indifference is being asked in every single exam. ठीक है, आई एम श्योर ऑल ऑफ यू गॉट इट राइट. दीज टू आर प्रीटी स्ट्रेट फॉरवर्ड क्वेश्चंस. डिटेल में भी with other options we will release the explanations, the videos, but this is recall where we are trying to wrap it up quickly. Again, third question, pretty standard, right? Grandiosity is about believing himself to be very rich. Nihilism, world has ended, the Cotard syndrome. Persecution, someone is planning to harm, and delusion of influence, thoughts, actions are being controlled. Interestingly, a question on delusion of influence was asked by FMG examiners last year, and now they have given this term influence in the INI-CET exam. Earlier, they used to use the word control or passivity phenomena. This term influence was used by FMG examiners and now in the INI-CET. ठीक है, ये क्वेश्चन सही है? Is this question correct? Aman is saying why not somatization? Aman beta थोड़ा सा conversion disorder के if you go a bit deeper ना, there has to be neurological deficit, lack of concern. In somatization disorder, it would be excessive concern with the symptom, not lack of concern. Again, this is a standard question. So A is with 2, B is with 1, C is with 3, D is with 4. I'm pretty happy. First, second, third question are from marathon also. Forget about the quick revision video or the mission videos. In the last 1.5 hours, we discussed all these topics. So this one also covered in forensic in marathon. A straightforward question. Sexual pleasure achieved by use of non-living or inanimate object is called as fetishism. I'm pretty sure most of you got it right. Frotteurism is about touching. Voyeurism is about peeping Tom. Exhibitionism is about exposing yourself. And this is fetishism. I'm sure most of you got it right. अच्युत बेटा आपसे ये वाले will create a strategy video now that INI-CET is done. We'll cover those points there. This is a question where some of you might have struggled, but again, you can easily rule it out, rule out the other options and answer it. But in this question, even if you struggle, that's okay. It's a new question. DMDT has never been asked in the past. मुझे एक बात बताइए, was it 6-year-old or 7-year-old? Was it 6-year-old or 7-year-old? Did the question say 6-year-old or 7-year-old? Can anyone answer in the comment section? Was it 6 years old or 7-year-old? 7-year-old, ठीक है. So a 7-year-old child has episodes of anger outbursts many times a week out of proportion of the situation and remains irritable for most of the time. So this is actually the classical definition of DMDD. But even if you did not know that, we remember in opposition defiant disorder, there is history of defiance, disobeying. In conduct disorder, we remember history of things like stealing, bullying, all of that. So you rule it out, you rule it out. There is no history of inattention, no history of hyperactivity. This is the last option left. So if some of you were able to rule out the other options and got it right, great. Otherwise, remember that in DMDD, the primary symptom is irritability. The child is always irritable. And then there are sometimes when he will have an anger outburst, verbally or behaviorally. So this is option D. There was another question on McNaughton's rule, which would be covered by Dr. Atul sir in forensic medicine. Zoya is saying angry was also mentioned, तो add कर देते हैं angry. Otherwise मेरा recall ठीक है ना? The questions that I have framed, are they okay? Anything I am missing? ठीक है, चलिए. All right, so who is next? Hi, hello sir. So Dr. Amrit is here. Sir, what is your analysis about the paper? Was it, I mean, the difficulty level and how many repeats?
The three questions were mainly PYTs. Some questions came from the recent INI FMG se bhi. There were a couple of questions.
Exactly.
Some
So difficult level,
very heavy. Surgery was, I think, compared to other subjects, quite manageable.
quite manageable. ठीक है. ठीक है sir, please carry on. Thank you students.
Hello guys, hope you're all doing well. Let's do our questions. So I have a good set of almost 18-19 questions and I have a decent recall. I think they are not too off. They are fairly accurate, but you can definitely help me and I'll quickly discuss them. right? And you can guide me along the way if there is something that is a little different from what we did. Okay, so let's get started. I have about 18, 19 questions. This question, standard question, this actually came in the last FMG exam. Patient had recurrent gastric ulcers, and there was a nodule which was seen in the second or third part of duodenum. So if you see something like this, recurrent gastric ulcers, you are thinking of gastrinoma. It's an endocrine tumor seen in Passaro triangle, and the next step is going to be serum gastrin levels, obviously. So the answer here will be serum gastrin, right? PTH, catecholamines. PTH is for primary hyperparathyroidism. Catecholamines is for pheochromocytoma. Don't go in some other direction thinking it is Men's syndrome. Okay. Gastrinomas occur without Men's syndrome also. So this will first be a biochemical diagnosis. All right. Okay. Okay. Insulin was also option. Thank you. Not that it matters, but yes. Okay. No problem. Now see this question. They had already given you the diagnosis that it's an inflammatory breast cancer. So long history was given, image was given, inflammatory breast cancer, and they had asked you what is the treatment. Inflammatory breast cancer is T4. T4 is locally advanced LABC. And in LABC, treatment is going to be neoadjuvant chemo followed by modified radical mastectomy. It can't be MRM first. How do you do MRM in LABC? Not possible. And normally in LABC, you avoid BCT. So BCT is also out. Palliative would be if there was any metastasis. Palliative is for M1. So best answer here, neoadjuvant followed by MRM. Okay, I hope oncosurgery at least you should not make any mistakes. Like oncosurgery is our bread and butter. This question helped me a little bit with because if the wordings are a little different, the answer will change. So they had given you a diagnosis of a patient with acute appendicitis. And which of these is correct? So there were multiple combinations, all of the above, A, B, C, D. So you had different combinations and you had to pick the correct combination, right? So first option was, yeah, it doesn't matter covering entire breast. It is still LABC only. Doesn't matter. So one option was McBurney's point is the classical site of tenderness. If these are the words, this is true. McBurney point is, but is it diagnostic? Answer is no, it is not. It is not diagnostic. But is it classical? Yes, it is. Oshner-Sharon is used in appendicular lump, yes. Interval appendectomy is done in all cases, no. If it's mild appendicitis, you don't need to do appendectomy. Okay, so no need for that. USG is IOC in children pregnancy, yes, it is. Is it a reliable clinical sign? I would say no. If you say reliable, no, it's not reliable because it's not always there. So these words, if they change the words a little bit, this option A is ambiguous. Okay, reliable, I would say no. So then it is 2 and 4. Okay, appendectomy is not done in all cases. No, it is not. So 2 definitely correct. 4 definitely correct. This one, the choice of the words will change the answer. Okay, fine. This was an easy question. They always ask some basic suture material, even in NEET, they asked which causes maximum reaction, and they had asked what is absorbable. So obviously, polypropylene is not absorbable. The polypropylene is out. Polydioxazole PDS, no. That is it will be there for a long time. Choices were between polygalactin and catgut. Of course, it will be catgut. Okay, catgut shows maximum reaction. That's why it gets the fastest absorption. It is destroyed the fastest. It won't be there for a long time. Okay. Again, they tried to catch you on this. They tried to catch you on this. They gave you an image and they asked you, like even in the last INI-CET, they had asked a bariatric surgical image. That time they had asked SADI sleeve. So hopefully this time you were better prepared. Maximum tissue retraction is the same thing. It means the same thing. It will be catgut. It will be catgut only. Maximum tissue retraction or reaction. Okay. One combo was BCD. Fine. So patient has come after obesity treatment. They had given you a surgical image. Now, if you saw 2 anastomosis, please remember 2 anastomosis cannot be mini bypass. So it can be Roux-en-Y. Now see where the anastomosis was done. If it was a GJ, gastrojejunal anastomosis, then it is not duodenal switch. Okay, in duodenal switch, there has to be a duodenal anastomosis over here. Means you first do sleeve, then do duodenal switch. If that was not the case, if there was a GJ, then it's either OMI or BPD. Okay, it's either OMI or BPD. And if some students told me they had given you common channel. The common channel was very small, something like 0.5 meters. ऐसा कुछ दिया था? 0.5 meters common channel. Looked like a OMI, but it had a small common channel. In that case, it becomes BPD. It's not a good question to put honestly because we don't do BPD anymore. It's an outdated surgery. But because it was asked in the previous exam, you would have been ready for it. Yeah. So if there was a GJ anastomosis, it is not duodenal switch, it's not mini bypass, it's either A or D. But if there are a short common channel, then it will be BPD. Okay. Yeah. So then it becomes BPD. Fine. Cool. Okay. This was a very easy question, and I'm sure you would have overthought, overanalyzed, and made a mistake. In the question, did they say there was spillage of hot milk? Their child has spilled hot milk or hot water, something on the hand, and they had given you Burns image. And options were superficial, deep, full thickness, eschar. वैसे full thickness and eschar mean the same thing. And the image was a forearm or a hand where there was just redness that you could see. Now, please remember, if it is something like a hot milk, please don't screw it up. It has to be superficial partial thickness. None of these will be seen in domestic burns. Okay, none of these will be seen in domestic burns. Ideally, there should be blistering. If there are blisters, then to very easy. Then to no rocket science. Okay, did you see blisters? Blisters, then choices. Easy. Image has to be incorrect. How will I get the same image? It was a forearm image. But you don't need the image. You just know hot milk is going to be superficial partial thickness. Okay, are we clear? Extreme red, even better. In deep partial thickness, it is white and mottled. And full thickness is black and charred. See, full thickness cannot happen from domestic burns. Okay, let's get that clear. Clear cut loss of skin doesn't matter. You spill hot tea on your hand and see. Okay, plain deep wound. The epidermis would be lost. Okay, fine. No skin was present. Okay, fine. It's super. Some skin is lost na in superficial partial thickness. Skin absent. Okay. कोई skin था ही नहीं. सुन लिया मैंने. आगे बढ़ो. This was a new question. Actually, it's not a very difficult question if you have reached till that point. But yeah, this is not given in Bailey. So they are asked, where do you use Tigaro? It's actually an etiology. Okay, it's actually an etiology. Etiological types. This holds good for chronic pancreatitis. Each of these stands for something. T is toxin, I is idiopathic or immune, G is genetic, A is autoimmune, R is recurrent. So all of these stands for the different etiologies of chronic pancreatitis. जिसमें most common is toxic or alcohol. Okay, so this is Tigaro for chronic pancreatitis. Right. Now look at this one. So they had given a surgical image of an open inguinal hernia repair. Sac was opened and some content was shown. And they had asked you, what content is it? And what is the name of the hernia? So this obviously is open to interpretation if it looked like an appendix, because students told me it looked, you could see tinea coli. So they said we could see it was colon, there was tinea coli and something coming out. So they said, okay, it's likely to be appendix. If it's appendix, it is going to be amide. Okay, but this is open to interpretation. Please remember, amide is appendix for inguinal hernia. Was option C was there? Garangio. Did you see anything like this? This garangio. Was this option was there? Garangio. Some was saying gibbon. Gibbon to nahi hai. Was this option there? Garangio by any chance? Because if that was there, na, it can become a problem. Yep. Later is Meckel's. Meckel's you can make out. It will be anti-mesenteric. Okay, chalo bach gaya. If Garangio was not there, then you are safe because Garangio is also appendix as a content. Just letting you know. Okay, so Greinfeld, this is a lumbar hernia. Okay, gibbon is hernia of hydrocele. So no problem there. Then the answer is amine if it is appendix. Then you are safe. Later is if it is Meckel's diverticulum. Meckel's will come from small bowel. So if it is small bowel, it is Meckel's. If it is showing all this mesoappendix, small diverticulum, then it is appendix. That will be amine. Okay, fine. Two surgical image questions were there on arrange, so they had given you different combinations. This was quite straightforward. First, you would obviously take the skin incision. I've taught this many times. Identify Gallett's triangle, dissect, get the critical view of safety. Once that is attained, clip the artery, clip the duct, and then remove the gallbladder. So this is a straightforward multiple sequences combination. Okay, this is a multiple sequence combination. So this will be obvious. Skin insertion, Gallett's, clip, and then remove. So you can't change the order here. Pakka, there was skin incision, right? Because I mean, that becomes too easy as the first step. Nothing else will be the first step. Please identify Gallett's first, okay? Don't clip first. First identify. Okay, very good. So create pneumoperitoneum. That will come first. Obviously, I mean, these are very simple, normal things. I hope you got them. Creation of pneumoperitoneum, right? Okay, that will be done before anything in the surgery, right? Dissect Gallett's, yeah, do you dissect Gallett's? That's fine. Dissect, identify, and dissect. It goes the same way. Then they had asked, arrange the steps of hernioplasty. This also was multiple combination. Okay, this was also multiple combination. So here also there was skin incision. Identify the sac, reduce the contents, place the mesh, wound closure. This will be the correct order. Okay, this was also straightforward. Open hernia repair, clear cut. These will be the steps. Okay, dissect Gallett, fine. No problem. Identify and dissect. Dissect above the R4U line. This is a repeat question where they had asked you, there was no image in this. What is the angle between left and right hand working port? This is manipulation angle. Okay, last time they had asked azimuth angle, if you remember. Yeah, last time they had asked this azimuth angle, previous INI-CET. So now it will be manipulation. So between telescope and instrument, azimuth, between two instruments, manipulation. This is a repeat question. Repeat means they just change the scenario. Otherwise, it is the same. This, I feel there is a trick. Students are not able to tell me. Okay, I feel there was a trick in this question. I think students have not recognized the trick, maybe. If it's, I don't think it will be that simple. So they had given history of RTA. Patient has brought to casualty. He has nausea, vomiting. Raised ICT findings were there. And two images were given. There was one image of the skull bone. Why would they give that? They had given one skull image, skull outline. And then the second image was a CT scan of EDH. If it's that simple, then it is decompression. Okay, yeah, two images of two times vomiting, fine. That's okay. So if it is this obvious, then answer will be decompression. Bore hole and evacuation. That's fine. That is decompression only. Then I feel it's a very easy question. I feel INI does not put like this. So if it is this, this is the answer. He has vomiting stupor or he's drowsy. Fine. That means he's having raised intracranial pressure. You will have to do a decompression. Okay, best management. Yes, decompression. That's fine. Okay. Match the following. This is also straightforward. I don't know what was the fourth option. See if you can remember. They had asked you to match. Manometry was for achalasia. 24-hour pH was for GRD. System EV was for parathyroid. I don't remember the fourth option. Okay, the students could not recall the fourth, but this was easy. Craniectomy is done in cerebral edema, not craniotomy. Craniectomy is in cerebral edema. Burr hole is a type of craniotomy only. Okay. You can tell the fourth option. Otherwise, even if you know three, it is fine. Means these are three quite obvious. There was a fourth option, C esophagus. Okay, that must be endoscopy. That must be UGI-scopy. PET scan. Okay, PET scan. PET taki EUS. Okay, EUS. Fine. No problem. C esophagus. When to do craniectomy if person is having cerebral edema, not in the setting of trauma. In trauma, you do evacuation. This is the most ambiguous question. Huh? Ambiguous means 10 students have given me 10 different versions. I have asked many students this question. They have given me something different. So please be clear and tell me honestly, was cholecystectomy done? Or was it a cholecystostomy first? So there is a patient who had a cholecystectomy is what people told me. Some people said cholecystostomy means tube was put with abdominal tube insertion. Now, normally we don't put abdominal tube. Huh? Normally we don't put. Okay, 7 days. Doesn't matter duration that much. And why does the patient have pain right now? And there is bile coming in the tube. Okay. And some imaging was done post-op day 7. So history of lap chole was there. What imaging was done? Cholecystectomy done. 200 cc bile was coming. Hmm. Bile leak on what? How do you know there is bile leak on in the tube? Any imaging was done? CT normal, CT normal. Okay. You are saying CT normal. That is strange. How can CT be normal if there is bile leak? MRCP showed stump leak. Okay, then it becomes very easy. This is the very easy. This is PYQ. MRCP showing stump leak. This becomes PYQ. Okay, stump leak, then it is ERCP with stenting. Simple. This is PYQ. Okay. Maybe Harvey can tell me the exact question later after this recall. Hopefully, if she still remembers me. So if this is Strasbourg type A leak, the answer is going to be ARCP. No, sir, no stump leak mentioned. See, this is what I'm saying. Two separate questions. Yeah, that's why there is confusion. If anybody can tell me that there are two genuinely different questions, then you let me know. Why not immediate percutaneous drainage? Because there is bile coming in some tube which is already put, no? There's already a tube which is put. Okay, fine. I think this question is fine. There must be a similar question which students are getting confused with. This is fine. This is cystic stump leak. Stump leak, it is the ERCP. This is Strasbourg type A. No question about it. Percutaneous is the immediate management when the person starts leaking, not right now. ERCP sphincterotomy means the same. You are going to put a stent. It's the same. Okay. Patient had recurrent abdominal pain, amylase lipase raised, there is recurrent pancreatitis. MRCP showed this image. This is choledogal cyst. Okay, this will be covered in radiology also. Okay. If anybody can help me with that bile leak question, please let me know. Huh? You can message me and tell me. Because I have asked many students, they are all giving different versions. If it was stump leak, then it will be ERCP and stenting. Okay, this was easy question. This is actually physiology more than surgery. About intestinal stoma. Ileostomy is pouting is correct. Loop ileostomy is usually temporary is correct. Colostomy has flat mucosa. Even if you didn't know anything about this, even if you know nothing about this, colostomy has maximum fluid loss is wrong. Colostomy will produce stools. Stools will come out, so there will be no electrolyte losses. This is seen in ileostomy, jejunostomy. Okay, that will be seen in ileostomy. Electrolyte losses. No. This you can confirm with radiology, madam. Okay, what was the exact image? Hmm. Colostomy is flushed only. That is correct. It means the same thing. It is flushed. Yeah, okay, maximum nikal do, more. That is still incorrect. It has more electrolyte loss. That is wrong. This is the incorrect answer. Chalega, no problem. Yeah, that's what I'm saying. Choledochal cyst only. This history sounds like choledochal cyst even without imaging. Cool. Okay. Late dumping, incorrect statement, occurs after 2 hours is true. 1 to 3 hours, aggravated by exercise is true. And relieved by lying down, this is wrong. Relieved by lying down will help in early dumping. Okay, this will help in early dumping, which happens because of hypotension. Late dumping is hypoglycemia. That will be relieved by eating more food. Okay. Colostomy doesn't have fluid loss. That is the incorrect answer. During triage, who gets maximum priority? A crying child, no. Unconscious patient with a noisy breathing sounds. What does this mean? It means he has airway obstruction. Obviously, airway obstruction will get maximum priority. Answer here will be option B. Okay. Answer will be option B. Airway obstruction. Okay. So then there are a couple of questions which will be actually taken in other faculty, like hypercalcemia, hypophosphatemia, osteoporosis. This is primary hyperparathyroidism. Okay, this is primary hyperparathyroidism. You will do Sestamivi scan. And pancreatic cyst, raised CEA, low amylase, mucin. This is mucinous cystic neoplasm. Okay, so these will be done by other faculty. Don't worry about it. They will discuss it in more. But for me, I felt, was there no question on urology? There are 18, 19 questions of surgery. There is nothing in urology. That's the only thing I didn't get, barring that lab coli question. वो छोड़ के I think all the other questions were correctly recalled, more or less. Maybe a few points here and there. And lot of PYTs again, typical type of questions. Okay, so that's it for me, guys. Just help me with that lab coli wala question on Telegram if possible. Okay, if possible. And now I'll hand it over to the next faculty. Mukta, please hand over to the next faculty. Who's coming next?
Thanks, sir. Thanks a lot. Just a second, let me just share my screen. I am not able to share the screen somehow. Just a second, let me just share the screen. Is my screen visible? Okay, I think now the screen is visible.
Yes, sir.
Thank you. So I am on the airport, so excuse me for some background disturbance. I will not take much time. Let's discuss it quickly. So I believe most of the forensic questions were from the PYT and all of were from the mission classes. Okay. So we are discussing forensic medicine and toxicology. Okay, I hope I am visible and audible. So very straightforward, crocodile skin, it is seen in high voltage burns. So very straightforward question. Is the question correct? Okay. Second, मेरा flight छोड़ो यार, question discuss कर लो. My name is Dr. Atul Gupta. I'm your forensic faculty. Okay. All are used in sexual abuse except Florence test, Barberio test, both are the presumptive tests. Presumptive tests for semen. It is the confirmatory test. Acid phosphatase is the confirmatory test for semen. And so the answer is range test. This is a test for detecting heavy metals, especially arsenic. Okay. Next question. Female is sexually harassed. Okay, now don't go to the police is wrong. This is a criminal offense. So the doctor has to mandatory inform the police. Mandatory inform police. It's a serious offense. Ask consent from female? Yes, of course. Victim is 18-year-old. So the age, if it is 18 or above, the victim herself has to give the consent. This is true. Ask consent from mother? No. Victim herself age is more than 18. So don't do examination? No. That is wrong. So first thing is to take consent from the female. Next question, the patient was, it's a very typical question. The cherry red color was there, and cherry red is typical of carbon monoxide poisoning, and there was no ventilation. Geyser was in the bathroom. Probably it was not electric geyser, because electric geyser will not produce carbon monoxide, but it is some other geyser which burns, which uses the burning of wood, coal, etc. Okay. So the answer will become carbon monoxide. Okay. All clear? So I'm just going a bit fast because you have done your exams, and moreover, I have a flight to catch, but just schizophrenic patient was there and he was having delusions, then he committed murder. So of course he is not guilty because he could not understand. It was delusion is a serious disorder that person was trying to kill him. Okay, so the answer will be not guilty. Next question. So hanging, the right eye was open. That is la facies sympathetic. So it occurs due to pressure on the cervical sympathetic chain. It occurs due to pressure on the cervical sympathetic chain. It's a sign of ante-mortem hanging. It's a sign of ante-mortem hanging. Answer is C. Okay. Then there was some burn patient was there. I didn't get the exact. Okay, vagal trunk may be the choice, but the answer will remain. Answer will remain cervical sympathetic change. Some burn patient question was there. I don't have the complete question, but there was soddening of skin was there. Soddening of the skin is seen in moist burns only, in scalds. So, okay, soddening means water going inside. So whether right vagus was there or not does not matter. The answer will remain the cervical sympathetic chain. Okay, answer will remain cervical sympathetic chain. Soddening of the skin occurs in the moist heat. There was some red line was there. So chemical burn do not have red line. They do not have vesicles. And soddening is characteristic of moist heat. Okay. So, and their burns are more on the lower side, dribbling down, or dribbling sign, splash sign that I taught you. So this is all moist heat. Okay. Then there's some actually here in this question where the age estimation was asked, the choices become very important. The problem is I was not able to get the choices. We have to confirm whether he is 19 or 17. So all the X-ray, wrist X-ray also helps. Shoulder X-ray also helps. These two help because these two fuse at 17 to 19 years. Upper end of femur also helps. This is also fusing at 17 to 19 years. Shoulder joint also helps. It also fuses at 17 to 19 years. So it will depend upon. So sacrum does not help. Sacrum fuses at 21 to 25 years. So sacrum will not help. Sacrum will not help. Elbow is not of much help because elbow fusion basically elbow is more useful between 13 to 16 years. So I don't know if some sacrum is not helpful. Sternum can be some helpful. So actually, unless I get the wrist, elbow, clavicle, pelvic. So hip was also there, skull, sternum. So I'm sorry, I'm not getting the exact answer. So I can't give the answer to this. But what I'm saying is that skull will not be useful. Don't think of skull. Okay. Don't think of sacrum. Sacrum will be less useful. So these two will not be the answer. Okay. So anyhow, whenever you get the right proper choices, you can share with me. I am not sure because I am not able to get the choices. Any other question? Any other question? There was one question on sexual perversion that Dr. Parveen will discuss. Any other? Yes, sternum can be useful. Sternum can be useful, definitely. Elbow, wrist, and sternum can be the answer. Yes, elbow, wrist, and sternum. This can be the answer. Okay, skull for gender. What was the question? Leave this question because I don't have the choices. We can discuss this later. Any other question? Any other question was there? Something on gender? What was the question on gender? Tell me. What was the question on gender was there? One perversion question was there that Dr. Parveen will discuss. Okay, I don't know. If there was some question on the sexual part, then answer will be perversion. Any other question, sexual determination, the answer will be pelvis. Okay, thank you so much. This all the best, and please share me further questions on my WhatsApp. Thank you. I will hand over to the next faculty. Thanks. Hi, Dr. Raina.
Hi, sir. Thank you. I will just share my screen. Just a second. I don't think the screen is visible. Okay, so it's visible now, I guess. Hi, everybody. So this was, I think from Obs and Gynae, most of you would have been quite pleased to see the questions which came from here. Not much asked, surprisingly. There were just 10 or 11 questions. And so we'll quickly go through them. This was a repeat question. It's usually asked now very often in all the exams. I think the same question came in last year's NEET PG also. So the optimal time, if it was asked postpartum IUCD insertion, then your answer is going to be within 48 hours. Remember, so this would have been the best answer. Remember, post-placental is within 10 minutes, but I think the question asked was postpartum. Postpartum is within 48 hours. You can put in a IUCD. All right, so I'm just looking at the chat box also. If any questions come in, let me know. Okay. This was also a repeat question, an exact same question from I think 2021 or 22 INI. And which instruments will you use in a cesarean section? Very, very straightforward, right? So we will use a Doyens, of course. We will use a BP knife and handle. We don't use a Shirodka. Shirodka is used to lift the uterus in hysterectomies. Carmen's cannula is used for MTPs. Cusco's is used for vaginal examination. Green Armitage and Alice forceps. So this is quite straightforward. So A, B, F, and G would have been the correct answer. Okay. So if it was post-placental, as some of you are saying here, then it would be 10 minutes. But if the question was postpartum, it would be 48 hours. So it all depends on what exactly was asked. All right. Okay. Next question was on pap smear, atypical glandular cells are seen. Now, atypical glandular cells can come either from the endocervix because that's where glands are, or from the endometrium. So what do we need to do? We always, whenever there's an abnormal pap smear, we always take a cervical biopsy or a colposcopic guided cervical biopsy and an endometrial biopsy. In fact, we also take an endocervical curettage. This also we take because we need to know where exactly the abnormality is from the endocervix or from the endometrium. So this would have been the best answer. All right, so the confusion on post-placental postpartum will go on. I don't know what was asked, but I've told you what the answer should be depending on what was asked. Right, so let's move on. Again, a very often asked question, 15 millimeter thickened endometrium in a perimenopausal or any woman above the age of 40 or any woman in the reproductive age group with a thick endometrium. What should you be doing? You should be doing an endometrial biopsy because what are we thinking? We're thinking of hyperplasia, and hyperplasia is always a histopathological diagnosis. So you have to do an endometrial biopsy. She was 35 years old. Okay, so as I said, irrespective of the age, any woman in the reproductive age group, if she's having an endometrial thickness of more than 12, some books would say more than 15 millimeter, has to be biopsied. We need to do a biopsy. Okay. So we should repeat a PAP after you know what the biopsy says. The biopsy might come normal, then you will repeat a PAP. But first, we always need to biopsy an abnormal pap smear. Okay, there's a question. This was not a OBG question. I feel it was just one of the options was relevant to OBG. So I put it here. It is more of a medicine or a pathology question, I would say. It was a question on different types of shock. And by chance, one of the options was uterine inversion causes which kind of shock? Uterine inversion causes neurogenic shock, right? And that was the correct option. The other options I'm not too sure, but these are the two options I got. That severe shock is when blood loss is more than 30 to 40%, and gram negative bacteria would cause endotoxic shock. So I'm not too sure, but definitely the obs and gynae option was the neurogenic shock. But then again, this is not really an obs and gynae question, except the option. There's another question, I think, no, on OC pills and risk of DVT. That was also like one of the options was from obs and gynae. Unfortunately, very few obs and gynae questions. Okay, a question always comes on PPH. I've told you this, always has to come. Uterotonics are given, but bleeding persists. The next best step is mechanical management. So medical, followed by mechanical, followed by surgical. In fact, medical and mechanical go hand in hand. If that fails, then we go to surgical management. All right. Okay. So then there was a question. This was a bit of a tricky question, I feel, right? If this was the exact question, let me know what the exact question is, which is not a test of ovarian reserve in the early follicular phase. Was this the question? Let me know. So, to be honest, all of them are done as tests of ovarian reserve. We do a day 2 FSH, we do a day 2 E2, we do a AMH, which can be done at any time of the cycle. But newer studies now say you should do AMH also in the early follicular phase, and we do an antral follicle count on day 2. So all are done on day 2, right? Okay, other options were devascularization and uterine artery embolization. All right. So here the best option amongst all of these would be estradiol, because estradiol per se is the least sensitive. We would never rely just on a day 2 estradiol. We always club it with, of course, the best investigation. If it's asked, usually this is the question which comes with what is the best investigation. It is an AMH. But if to be honest, all are correct, but the least sensitive is the day 2 estradiol. So this would have been the best option. Okay, so this is the question did not mention early follicular phase, then estradiol, because estradiol is the one which we actually do all of them in the early follicular phase, but E2 specifically on day 2, because in day 2 all the hormone levels have to be on the baseline value. If you're finding a raised E2 right at the beginning, it is a marker of poor ovarian reserve. Okay. So all are signs of impending eclampsia. Again, this is direct PYQ. Same question has come in the past, and we all know the answer here is pedal edema. Pedal edema can be physiological. In fact, it's been removed from the definition of preeclampsia. Many years earlier, it was actually a part of definition of preeclampsia. But since the longest time, it's removed from there because it could be physiological also. So it is not a sign of preeclampsia, neither is it a sign of impending eclampsia. So headache, blurring of vision, and epigastric pain are signs of impending eclampsia. There was a question on the NACO kits. Now, the NACO kits, the question which was asked, a list of symptoms were given, and they said for which symptom is the NACO kits not given in men? Just a second. This is persistent pedal edema. So in men, where will you not give the NACO kits for which symptom? I think this was lower abdominal pain. Lower abdominal pain, remember, is a sign of PID, where we give the yellow kit. Okay, and this is given in women who have PID, and it is not a symptom for which we give a NACO kit in men. Right, so this was multiple option. This was not there. Inguinal swelling, lower abdominal pain. This was multiple option. Okay, was there anything else? So vaginal discharge is of course also something which we will not give for men, because vaginal discharge is for women, where we give the green kit. So the green kit and yellow kit are usually specific for women. Okay, so it was a multiple option correct answer. This was not there. Syndromic approach was not there. Okay, so I got this question, but remember the yellow kit for PID, that is lower abdominal pain when the symptom is lower abdominal pain, and the green kit for vaginal discharge are specific for women. It was not multiple. Okay, it was not. It was there, but it was not a multiple option. Understood. Okay, yes, NACO kits are the same as the STI kits. Next is strawberry cervix. We all know this. I don't know if there's an image or not, but the question was what is the causative organism and what is the treatment? The causative organism is the protozoa Trichomoniasis vaginalis, and the treatment is oral metronidazole or secnidazole or tinidazole. And we always give partner treatment also. So I do not know what the exact question was. Trichomonas, yes. Correct. Last question was multiple correct, the preeclampsia one. Okay, this was multiple correct. Got it. Understood. Was persistent fetal edema, 4 options were given, for which eclampsia was asked. Got it. So there was an image here. This was an image-based question where the strawberry cervix was given and the treatment was not asked. Okay, only the causative organism was asked. Got it. So I will correct this. So very easy, straightforward question. One question from vaginitis is always usually asked. Then a question on placenta previa. There was given a scenario, a placenta previa at 30 weeks with minimal bleeding. Okay, that's what was mentioned. Vitals were stable and she's not actively bleeding. So what will you do? You will follow the McAfee-Johnson line of management, which is conservative management. You won't rush for delivery at 30 weeks. Placenta previa is where you have a role of waiting. Waiting till when? Till 37 weeks, or SOS if she has another bout of heavy bleeding or persistent active bleeding, or if their vitals deteriorate, or if there's fetal distress. Fetal heart was 140. Okay, blood pressure was 110/70. Thank you all so much for adding to this. Hospitalization, admit and give conservative management. One option was expectant, correct, right? Now, admit and give expectant management. So yes, you will definitely admit her as part of McAfee or Johnson. But anything else? What was the fourth option? Okay, so that ends obs and gynae. Okay, so thank you so much for helping me out. But as you can all see, obs and gynae was quite straightforward. And I'm very disappointed that very few questions came. But I'm glad that you've all answered well, and all the best for the result. So, I think Dr. Zainab is next.
Hi, ma'am. How are you?
Yeah, hi, I'm good. I'll just stop share.
Yes, ma'am. I think this is the first time in history that radio questions are almost equal to OBGY. So we'll start off by discussing the radio questions. I hope it went well. A lot of integrated stuff. This time they did not bother us with, one-liners, signs. So that was the good part, that it was very clinical. That's how radio should be asked. Okay, so I hope you guys can see me and hear me. And you can see my screen, and you had a good exam. My overall opinion on the exam was, it was on the trickier side. It was prototype INI, first, second prof heavy, weird biochem, weird anat. That's how it usually is. Since the last 2 exams, it was a little atypical. Being so straightforward is atypical. Okay, so, that is what the paper is. We will be doing one more recall tomorrow where I'll talk about all questions together. But right now, let's do radio. All right. So this is the first question. You had an HIV positive patient with fever, you have cough, hemopsis, something which is pointing towards an infection, right? Here the student said ki X-ray is not very typical, but if this was the image, this is pretty typical, where you can see fibrosis in the upper lobe, you can see bronchiectasis. So this is what, TB looks like. Was this similar to the image that you got? So in that case, anyways, I think you were able to solve using history. Yeah, I'm happy that you guys could hallucinate me. Some happy hallucinations. Yeah, so this is what we will go for TB, because the other options don't fit. Clearly, it's not an abscess. You know what abscess looks like: horizontal air fluid level. Metastasis, cannonball metastasis, multiple nodules, not there. So I think, but अच्छे students भी बोल रहे थे कि मैम या तो pneumothorax था या TB था, but clearly history is not pneumothorax, so TB. ठीक है, yeah, I know this was not the image. Image देख के थोड़ा pneumothorax जैसा लग रहा था. That's the opinion I also got, but I have not been close to finding finding the real image. Nobody else also could find. So I don't know what they gave, but the history points to TB. So I think there's no doubt in the answer, irrespective of what the image was. ठीक है? Not low grade fever. Fever was not frequently. अच्छा, but फिर भी बैठे बैठे why would HIV positive patient get pneumothorax, right? So that I don't know how they would have linked pneumothorax anyways. So highest probability of it being TB only. ठीक है, अगर fever नहीं भी था, still we will have to go ahead with TB out of the given options. Do you guys agree with that? ठीक है, चलो next. 65-year-old male with tingling numbness in the arm, visual problems. I'm like, this is paraphrasing. I'm sure they would have given symptoms of Horner syndrome. So if they have given meiosis in ophthalmos, that further helps. So this is clearly from the history itself. You know, this is Pancoast tumor. क्या ये X-ray ठीक लग रहा है? For Pancoast tumor, ऐसा कुछ ही होगा, superior sulcus tumor. Yeah, so this is where they had asked you the next step or the best investigation. So अब देखो, ultrasound has no role here, right? So in the lungs, ultrasound no role except for pneumothorax. NCV is nerve conduction velocity. काफी बच्चों को वो ही नहीं पता था. So hopefully you did mark it then. So nerve conduction velocity will not help us here. We know the cause is Pancoast. It's not a neurological cause like myasthenia gravis, which I'm suspecting, right? So no role of nerve conduction. Sputum for microscopy? No. Again, for TB? No. So here we do a CT guided biopsy that will confirm that it's indeed a lung cancer. It's a Pancoast tumor. MRI hota to maza aata. But that 100% of you would have gotten correct anyways, because you know Pancoast tumor investigation of choice is MRI. So they knew that you know. So that is why they made it CT guided biopsy. So fair enough. ठीक है. Visual problem, why? Because sympathetic system, Horner's, Pancoast, very typical. Okay, right? So that's why the best answer here, without any doubt, would be CT guided biopsy. This was a PEDS radio, not even a radio question really, but I've just like sequestered it. So this is a term neonate who's gotten respiratory distress, prominent vascular markings. इतना सब कुछ ही लिख दिया. Condition resolved spontaneously भी लिख दिया. Then there is no point of asking this question. So I hope that they did not write this. So with thickened fissures, more vascular markings, what you expect is transient tachypnea of newborn, right? So this is what is the answer. अगर ये भी लिख दिया, then they have left no doubt only. Then I don't know why they have asked this question only. Right? ये भी लिखा था क्या? Was this written? How can we do a biopsy without MR? Because there's no option, dear. There's no MRI in the option. So what do? Right? You can't hallucinate MR option and then mark it when it's not there, isn't it? So that's why we choose the best answer, not the correct answer. That's the rule of all exams. लिखा था. चलो फिर ठीक है. फिर क्वेश्चन खत्म हो गया. This question, again, so many times we have discussed EDH. Burhole is 10 years back, right? So if anybody is giving you Burhole as the answer, it's wrong. Okay, it was relevant 10 years back. So here what the answer is decompressive craniectomy. So this is decompressive craniectomy, which is what is done now. नहीं इतना simple नहीं होगा ना अमर कि nerve था तो nerve conduction velocity. You can't generalize like that. Nerve conduction velocity is when you are expecting demyelination versus axonal. That's where you do NCV. There's no role here. We are knowing the cause, which is Pancoast. ठीक है. So swirl था तो कोई बात नहीं. Basically this is EDH and you are having a patient who's having loss of consciousness. I think stupor word भी use करा गया था, right? So stupor भी use करा गया था. So which means you have to act on it. You can't just observe him. You can't do conservative. I think एक option mannitol था, right? Not conservative. One was mannitol. Mannitol is contraindicated in EDH because it allows for more room. वो brain में से volume कम करेगा, which allows for more room for the hematoma to expand. So we never use mannitol in EDH. Burhole can be done if they write remote setup, PHC, no neurosurgical setup. ऐसा कुछ नहीं लिखा है. What is done in today's day and age is always a decompressive craniectomy. Yeah, so same question we have discussed in our ENDs also multiple times. ठीक है. So this is what the answer was. Not Burhole dear. Decompressive craniectomy. ठीक है. Only craniectomy was there, ठीक है. So that is decompressive craniectomy. That is what is done. If surgery faculty has said Burhole, I can discuss with them. But like my answer would remain craniectomy as the better answer. Okay. Next, what do you see here? 13-year-old child presents with arm swelling and pain, and there was a ill-defined diaphyseal lesion. Whenever you have such a lesion, there are two main considerations. Either it's osteomyelitis or something that mimics osteomyelitis is Ewing sarcoma, right? So where you see this permeative, not very, very well delineated diaphyseal lesion, right? Was this image okay? So this is what is Ewing sarcoma versus osteomyelitis. You know, Ewing's can also have inflammatory symptoms. That is why it's important to distinguish it. So how can we distinguish? Now, this is little tricky. See, PET-CT and CT are out. MRI will help us diagnose, biopsy will 100% help us diagnose. So अगर वो पूछ रहे हैं कि next step क्या है, then it would be MRI, because MRI will help us diagnose osteomyelitis, you know, bone marrow edema, osteomyelitis. MRI is the investigation of choice, right? Even a tumor, MRI will better delineate. So I feel first you will do an MRI, we will directly not proceed for biopsy anyways. So अगर हमसे पूछा जा रहा है what is the next step, you will do an MRI, try to find out the diagnosis, see the bone marrow edema pattern, and then do a biopsy, right? If the image look different, still the answer still remains the same, right? The train of thought remains the same, that is it osteomyelitis, is it Ewing's? So we want to do MRI before we do biopsy. Does that make sense? Okay, हाँ, वो biopsy मतलब bone marrow biopsy ही होता है, ठीक है? So bone marrow से biopsy लेंगे, so that doesn't change anything, ठीक है? Okay. This is the tricky one where you have different opinions based on what you have marked, right? So there was a patient who has chronic abdominal pain who has elevated amylase and lipase. So first of all, when you have amylase lipase with normal exocrine pancreatic function, first of all, what are they saying? That it's not chronic pancreatitis, right? That is what they are saying. Maybe acute pancreatitis or choledochal cyst sometimes can have elevated amylase and lipase as well, because they have an anomalous pancreatico-biliary junction, because of which these levels can increase. Okay, so technically, this can increase. But with normal exocrine, they've ruled out chronic pancreatitis for us. Annular pancreas में कोई भी आपको MRCP नहीं दिखाएगा कभी भी. They will show you a CT where they show that pancreas is encircling. So the sheer fact that it was MRCP rules out annular pancreas. So now we are left with two options. Was it choledochal cyst? Was it annular pancreas? Now, the students I've interacted, they've said this was the image. What do you guys think? Was this the image? Then I will tell you the answer, because otherwise it's just bias. Then you will say that, ma'am, ये image नहीं था, अगर answer divism नहीं था. So if this was the image, then you can see a fusiform dilatation of CBD. So if this is fusiform dilatation of CBD, this is what is a choledochal cyst. This is the gallbladder. This is dilatation of CBD, right? I will tell you another image. Look at this image. This is where the CBD is not very much dilated. And what do you see? You see two ducts in the pancreas. In fact, our last BTR mock GT, I gave you divisum question. I was expecting it, but I don't think divisum was asked. So that's why I'd given you divisum. So in divisum, you will see कि एक duct है जो कि ऊपर खुल रहा है, and then there is the other duct. So the bigger duct opens in the minor papilla and lower duct opens in the major papilla. And that is why this predisposes to pancreatitis. So the history actually points to divisum. Yeah, but the image that you guys have said, you know, that it was like this is not divisum. So now it will all depend on what image came. ठीक है? Annular pancreas में तो MRCP आ ही नहीं सकता. It will not be shown, because that is where the problem is, not the duct, right? What MRCP shows us are the ducts. So annular pancreas is out because MRCP was shown. That's how confident I am. Because there, they cannot give you MRCP image because it blocks the duodenum. Do you get it? Double bubble का DD हो जाता है. So वो तो out है. It remains कि इन दोनों में से which image was closer. Nobody seems to have the exact image, right? So that is what is important. GB पूरा circular था, annular, उसका तो annular pancreas वो नहीं होता बेटा. Annular pancreas is pancreas which has not rotated. तो उसमें gallbladder जैसा round around कुछ नहीं दिखेगा, right? So it's okay. It's not annular pancreas. Right, so if this was the image, this is choledochal cyst. If this is what was the image, it's divisum, right? So I've given you both versions. I feel it was choledochal cyst based on this image, which is more reliable, right? Okay. This one, was this asked? Involuntary movements, personality changes similar to Huntington's chorea, and MRI was shown. What is MRI showing? Caudate, right? You know, chorea, caudate, caudate atrophy, boxcar ventricle. This is Huntington's. I think options were Tourette, etc. So this is Huntington's chorea. This we have discussed. Yes. Next. This was a little tricky one. So now look at this image. This is what I could discuss with the students. I think this is the same image which was asked, but they did not ask you yellow arrow, right? And I would believe they cannot ask you yellow arrow because what yellow arrow is pointing towards is the vestibular aqueduct. They can't ask you vestibular aqueduct. That is literally like resident level question. So my gut feeling also says that yellow arrow cannot be asked to you. I mean, it would not be right. What would be right would be this. What is this meatus which is leading up to the inner ear here? This is the cochlea. This is the internal auditory meatus. All right. Was this the image, guys? So this is internal. External auditory meatus bahar hoega, right? It will be external. So this is not EAC. I think another option was carotid canal, which does not come at this level. It comes here near the jugular fossa, right? So it will be at a lower level. We will see that. So if this was the image, if yellow arrow was asked, the answer is vestibular aqueduct. If white arrow, jo uske aage hai, was asked, that is the internal auditory canal. Okay. So yellow arrow pucha tha to vestibular aqueduct, which I feel is like very unfortunate that they are asking vestibular aqueduct on the CT. But if not, this is internal auditory meatus. So now the exam is done. Doesn't matter what you have marked, what was asked. Now for future, we know that this is IAM. This is what is vestibular aqueduct. So that solves the purpose of this question. Yeah. ठीक है, येलो एरो ओनली, तो फिर तो वेस्टिबुलर एक्विडक्ट होगा इफ येलो एरो. सो आई मार्क बोथ ऑफ देम इन द आंसर. अब जो पूछा था वो देख लेंगे. Okay. Next. This was easy. Emergency patient and CT was shown. For a change pneumothorax, they showed you CT. I think X-ray CT दोनों ही दिया था, but CT was where most students could identify that there are no bronchovascular markings, there is free air, kala air. So what do? Needle, right? ऐसा दिया था. Unstable patient है, needle thoracostomy. Yeah, do you guys agree with this question? So this is what is pneumothorax. Yes. All right. Why not ICD? Because unstable. Agar stable diya hai, then we can do ICD. So yeah, it would depend on vitals here, but the diagnosis for sure is pneumothorax. So we've reached 9 questions, integrated radiology. Yeah, and I have like one more medicine related question where they'd given a patient with rheumatoid arthritis and dyspnea and probably a HRCT like this was shown. So this would be methotrexate related fibrosis. I think it was multiple correct. I'm just discussing the radiology. I did not gather the 4 statements. I'll do that tomorrow. So methotrexate fibrosis related CT. ठीक है? नो व्हाइट एरो. हाँ, तो अब व्हाइट एरो येलो एरो छोड़ दो, कोई बात नहीं. अब दोनों पता चल गए. वॉट एवर वॉज आस्क्ड, नाउ दैट्स डन, राइट? सो फॉर फ्यूचर वी नो दैट IAM CT is also important. ठीक है? All right, so that's it for radio. If you have any other doubts, save them for tomorrow. We'll discuss all questions tomorrow as well. So, you know, this is what is the initial version that I've gotten. If you have any comments, please, you know, type it in the comment and I will modify any option or question wording. ठीक है? Okay, thank you so much. Good luck. I think Anand sir is next. Hello, sir.
Hi, ma'am. Hi, ma'am. Good evening. Yeah, hi. Hello, everyone. So the first question was regarding transient tachypnea of newborn. They had a term baby, LSCS section with distress. One of the important questions for transient tachypnea of newborn. And one MCQ we had of continuous machinery murmur. Preterm baby, continuous machinery murmur, we should think of PDA. And one more question we had regarding the 15 chromosome deletion. I'll repeat again. 15 chromosome deletion was there. That was regarding Prader-Willi or Angelman syndrome. So 15q deletion, Prader-Willi or Angelman syndrome. Regarding that, the question was there. So I'll repeat again. The first question was from neonatology regarding transient tachypnea of newborn, term baby, LSCS bone having distress. Second question was regarding cardiology. continuous machinery murmur. That was regarding the PDA. And the third question was regarding genetics. That was Prader-Willi or Angelman syndrome. Basically, chromosome 15 deletion was there. So that was very important. So these were the questions we had over here. And there was a question on milestones. So every system, one question was there regarding the milestones. A baby can transfer objects from one hand to another, like that question was there. A baby can transfer objects from one hand to another was 6 to 7 months. So every 1 month system had a question from neonatology TTN, from cardiology PDA, from milestone the question was there, and from genetics it was chromosome 15 deletion, that was Angelman or Prader-Willi syndrome. So I'll that's all about pediatrics. Thank you so much, everyone. So I'm traveling somewhere, and once I'll make a proper video about it and I'll share it. So thank you so much. That's all to me, and I'll hand over the mic to the next person. Thank you so much.
Hello everyone, can you see me or can you not see me? Is my screen visible? One second, let me try again. Hi guys, can you see me? And can you hear me?
Good evening, ma'am. Yes, ma'am, you are audible.
Acha, ठीक है, I'm just sharing my screen. Okay, so hello everyone. Okay. Hello everyone. How was micro? I have gotten a lot of mixed reviews regarding micro. Screen is not visible, guys. It's visible. Okay. So I got very mixed reviews regarding micro, and I think it was mostly previous year topics. But yes, they were twisted, right? There were no direct, I would say, repeat PYQs. They were definitely twisted, but mostly the topics were pretty much the same because kitna, you will ask from out of the syllabus. So let's go on with the first question, guys. You have to help me with the options also. There was a history of some farmer who had the following image with black granules in discharge. This is the kind of history that was given. Most likely organism, given the history, we are looking at something which is your mycetoma. And we all know that it is caused by either a fungus or a bacteria, which is nocardia. And here we will rule out staphylococcus and actinomyces because we know actinomyces causes lumpy jaw. So here it has to be nocardia or Madurella mycetomatis. And because there were black granules given, we have to mark Madurella mycetomatis because nocardia is usually your reddish to white colored granules. We all know red to white colored granules hota hai, so this is not going to be the answer. The answer is option number D. Acha, even if farmer is not there, it's fine. We all know that this is mycetoma. Right? Simple. Moving on. Which of the following is an obligate intracellular organism? So we all know here obligate intracellular. That means can't survive outside the cell. It is going to be Ehrlichia schaffenensis. We have things like chlamydia, anaplasmacyto. All of these things are the ones that are going to be obligate intracellular. Butyromycosis, guys. When I told you in mission classes also, butyromycosis does not have any pus coming out of it like this, right? It is going to be more like a loculated thing. And again, black granules are not seen with staphylococcus. Even if it is butyromycosis, black granules are not seen. So amongst the following, obligate intracellular, we know that is Ehrlichia schaffenensis, right? Very, very direct question. Not C, triple villi, no, it is not obligate intracellular. It is there, but it is not an obligate, means that it can't survive outside. So it's going to be A. All can be caused by thorn prick. Me having to repeat this multiple times that guys, only thorn prick is not for your sporothrix. It can happen with any of the subcutaneous mycosis, right? And we all know that very famous mnemonic of MRCS, right? These are the 4 organisms causing subcutaneous mycosis. There is only one here, which is your dermatophytosis, which is your superficial mycosis. This is the only one. This is the only one that is going to be not transmitted by some kind of a thorn prick. है ना? So we all know dermatophytosis इसमें yes, mycetoma, black granules बात खत्म guys. Thank you Akanksha. Simple. ठीक है, moving forward, match the following. ये भी we had done. Remember last में mission class में end में I had given you the table of difference between larva currents and cutaneous larva migrants. Very good, Amar. So very quickly, larva currents, I told you, it goes like a current and it is going to be strongyloids. Then visceral larva migrant, something that was not supposed to infect you, goes inside your body. We all know that your Toxocara canis is the one. that causes visceral larva migrants. Then cutaneous wala, matlab on the skin going inside your body. I had shown you this, that is Ankylosarcoma brasiliensis, right? Zika 2, and then finally zoonotic schistosomiasis. I believe this was given. It causes your swimmer's itch because it goes by this filariform larva that enters through your foot and everything. So it's going to be D is 3. So I hope everybody marked this and these are the correct options. Right, guys? Are these the correct options? Match the following mein. Please help me out very quickly. I am not able to see any chat bot, or are you guys not writing anything, or is it stuck? Okay, I'm going to move forward then. Okay. Guys, just help me out here. Was there some kind of a fungating mass which was there over the mitral valve or something? Aisa type ka question was there. Let me just, I think my net is stuck there. Let me just start from here. Okay. 1 second. Okay, now I'm getting the messages. I don't know, my net is stuck from here. Okay, so Ascaris was also there, guys. In this, Ascaris was there. If okay, if Ascaris was there, then what was the thing that was going to be marked? Ascaris tha, so what was the opposite to it? Was it Loeffler syndrome? Was it any kind of X? If Ascaris was there, guys, then what was it supposed to be marked with? Ascaris instead of Toxocara. Are you sure? Acute branched. Acute angle. Guys, this is going to be this is your parasitology. Acute angle wala to is something that we're going to talk about in the aspergillus. Visceral ascariasis. Okay, are you saying that this was not there and ascaris was there? If this was there, okay, then my answer is going to still remain the same. Toxocara hi tha. Okay, guys, you're confusing me now. If it's Toxocara, then also it's the same thing. 4 diseases, 5 organisms. Okay, if it was 4 diseases, 5 organisms, ascaris is not matching with anything. It's not matching. The answer is going to still remain the same. Okay, fungating mass over the mitral valve, a silver or gomori methamphetamine image was given. I believe this was the image and you had to identify the organism. This so we know by heart. So we have been doing in and out and we know it by heart. ठीक है, Excite 4 था, Excite 5, Ascaris is not matching with everything. That was not going to be there. Toxocara causes your visceral larva migrant, so that is going to be there. ठीक है, guys. So we all know that this is the aspergillus. हाँ, तो acute angle branching था. I'm not visible, guys. Simply saying here acute angle branching image. Yes, so we all know that this GM is staining. We are seeing the septate hyphae. We are seeing this acute angle branching. This is going to be aspergillus species. बहुत सारे buds. What do you mean by buds, guys? बहुत सारे buds भी थे meaning? What do you mean by buds, guys? Okay, I'm just gonna shut this and see here. Chalo. Guys, just please very quickly give me the option number D here. What was the last option here? Okay, guys, I moved on from Ascaris. Can you very quickly tell me ki what was the other thing here? Another option here. Budding hyphae was mentioned in the question. Okay, great. So budding hyphae was mentioned in the question. Okay. Budding type instead of branching. Okay, but if this image is given, guys, if this is the image that was given, we all know these are septate hyphae, right? These are septate hyphae. So then it has to be your aspergillus. Okay, blastomycosis. Thank you, Sakshita Pal. Blastomycosis. Okay, even if it is branching hyphae, done, guys, done. Moving forward. Biosafety level, Mycobacterium tuberculosis, we know that it goes by aerosol, right? It goes by aerosol. I think this might be covered in PSM also. It is going to be BSL-3, right? It is going to be BSL-3. Simple. Image was same. ठीक है, then the answer is going to be aspergillus. It's okay if you don't remember. Mycobacterium tuberculosis, BSL-3, khatam. Moving forward, okay, this was something which you might feel was a little bit twisted, but for me, I think it was a very, very direct question. Life cycle of the organism is provided. Identify the correct statement. So, looking at the life cycle, what are we seeing? We are seeing these bats, right? We are seeing these bats. We are seeing fruits. That means these are kind of fruit bats, right? And then we are seeing these pigs that are transmitting, and sometimes even direct transmission can happen in humans. What is this organism? This organism is going to be your Nipah virus. Now you had to draw the correct statements for Nipah. So what is it? Humans acts as a reservoir host? That's wrong. So we know that the bats are the reservoirs. They are the ones that are transmitting it. Candida was there, ma'am. I guess it's okay if that is there. It causes, we have to find the correct statement, guys. So it causes encephalitis. Yes, it does cause encephalitis. Is there 100% mortality? No. 60 to 70% mortality is there. DNA virus? No. Remember, anything beyond that happy mnemonic, this virus does not come under the happy mnemonic. It is an RNA virus. So again, the answer is going to be option number TB. Guys, TB कहाँ है? Candida option में तो मैंने डाल दिया guys. यहाँ पे I have. Okay, somebody is saying Candida है option में. Even if Candida was there in the option, guys, it still does not. Rhizopus हटा के Candida भी कर दूंगी, तब भी the answer remains the same. I'm not changing my answer. Okay. हाँ, so I've moved on to the next one, guys. Nipah की बात हो रही है. We're talking about Nipah. The answer is going to be it causes encephalitis. This is the only correct statement. Rest all of them are the wrong statements, right? Okay. Moving on to the next one, we have question number 8. Patient presents with pulmonary symptoms after a recent visit to Northeast. I believe this was the kind of question. Chest X-ray was done. Guys, please help me. What was given in the chest X-ray? Everybody kept telling me, ma'am, chest X-ray. Not correct asked. Not correct asked. Then the options have to be different, guys. If it was not correct, then these are, I don't think not correct. Incorrect. अगर incorrect पूछा था, guys, then you have to give me other options because 3 of them are going to be the incorrect statements. Was it like a multiple option thing? Correct was asked. Now, guys, even I think correct was asked because all the statements here are going towards, 3 are incorrect, 1 is correct. How can they ask the incorrect statements? Okay, I'm going with correct because most people are saying correct. Patient presents with pulmonary symptoms after a recent visit to Northeast. Chest X-ray was done. Chest X-ray में what was the thing, guys? Okay, one is saying ivermectin. ठीक है. Okay, guys, I'm done with the correct option. Chest X-ray was done. What was there? History was given of ingestion of some crab, and stool wet count showed this egg. So we all know this dhakkan wala egg is going to be the operculated egg, right? Operculated egg we all know is seen either in Diphyllobothrium latum, right? And then it is also seen in your trematodes. ठीक है. अब इसमें there is only one trematode that is causing pulmonary problem with crab का ingestion because it is the second intermediate host and that is going to be your Paragonimus. Paragonimus westermani is the one. Photos of crab was given. Okay, if photo was given of crab, ठीक है. No X-ray was shown. Okay, X-ray was not shown. Ivermectin or DEC was given. Okay. So if this was all, we know that the drug of choice for all trematodes. What is it for all trematodes except your fasciola hepatica? For all of them, it's going to be praziquintal, right? It's going to be the praziquintal because only tricarbendazole is for fasciola hepatica. Rest for all of the trematodes, it's going to be praziquintal. DC was fourth option. Thank you, guys. Thank you so much for completing the question. ठीक है. My answer is going to be praziquintal. I hope ये तो पता ही था. ठीक है. So simple. See that they have given the image and what identify the organism by the image. I think this is the kind of question that came. It is so easy. We all know that these 4 blastomeres that are there, it is related to some kind of a hookworm. Both hookworms that we have, the Nicator americanus and the Ankylostoma, right? Or both of them show the same kind of eggs. And in the question, you were given Nicator americanus, so answer was going to be option number A. ठीक है? Guys, got it? Is this correct? Can I move forward? Chalo. ठीक है. Moving on. A patient presented with keratitis. Okay, this is something where I'm a little bit confused, guys, because they gave a history of contact lens wearing. And this, which stain would you use to identify the organism? Did they say anything else related to the contact lens? Ankylosarcoma was the option. Okay, if ankylosarcoma was the option, still the answer is going to remain the same, guys. Okay. Did they give you any of the other, hint in this question? Because there are two organisms that cause problems. One is going to be your Pseudomonas and another one is going to be your Acanthamoeba. So both of them are causing problems in the contact lens wearers. Okay, there was history of some watery discharge. Was there an image? Image was given. What was the image, guys? Acanthamoeba keratitis image was given. Oh, okay. This I didn't know. Image of Acanthamoeba keratitis. Okay, eye ka image was given. Guys, please, if you have that image, just please send me that so that I know. Congestion redness with contact lens history. Okay, there was congestion and watery discharge. Please, I need that image, guys. White ring-like thing inside. Okay. So it was like a ring-like thing, and if it was a Acanthamoeba, then we know that our answer is going to be calcofluor white, because calcofluor white is the thing that works for a Acanthamoeba. It is going to be taken up by the cell wall of it, and the trophozoite, motile trophozoite and all, like the trophozoite will become visible. Some white, intense painful, okay. Intense pain tha. Ring tha cornea pe, yes. So all of this is going to point towards the Acanthamoeba keratitis. My answer is going to be, even if it was modified GMS, guys, we don't do this for Acanthamoeba. Answer is going to be calcofluor white. It is one of the very good stains that takes up. Okay? Okay. Okay, moving on then, identify the organism and demonstrate this positive test in the image given below. So what is the positive test here? We know that this is going to be your germ tube test. Right? So germ tube test hai. So germ tube test, so we know that it is positive in only two organisms. One is your Candida albicans and another one is your Candida dublinensis. So ye to germ tube test, we all know that this was there. Guys, I've moved forward now. Can we just go ahead? So this is germ tube test. I think this was the question and the answer was going to be option number A. Simple. I think very, very easy. So we didn't have dublinensis, we had albicans. So the answer is going to be option number A. Right? I'm just reading your comments also side by side so I know. Okay, moving on to the next one. We had this Butyraria panprofta microfilaria seen in peripheral blood. Where is it present rest of the time? So they are basically trying to ask you about the diurnal variation. Right? It is trying to ask you about diurnal variation, that when it is not present in the peripheral bloods, where does it go and hide? At 37 degree? Okay, even if it was mentioned at 37 degree, guys, it doesn't matter. It's still going to be Candida albicans. We know that these are only the two organisms that show the germ tube positivity. Okay? So, microfilaria. Yes, the answer, guys. Okay, so this was something that I think a lot of tricky thing was there in this. So had they asked about some kind of a lymphoid tissue or something, because spleen may the microfilaria are not going and hiding per se. It is the RBCs that might be there that are kind of including the microfilaria. They are going into the spleen and making it bigger. Microfilaria particularly goes and resides because it needs that life cycle to be completed inside the lung. So the lung is the part. That is why it also sometimes causes this pulmonary pneumonitis kind of thing. Even if, okay, kidney was not given, skeletal muscle was given. Even if skeletal muscle was given, guys, the answer is going to be lung. Lung is where it goes and resides, not kidney. Okay, ठीक है. Capillaries of which organ? So it goes and resides in the capillaries of lungs, guys. This was a little bit tricky question because right now, till now, they used to ask about the sheath and the nuclei and everything. But now suddenly this time they've asked you a little bit of a practical question that, or rather not even practical, more of a theoretical question that where does it go and hide? Okay, so it's going to be, even if skeletal muscle was the option, guys, it doesn't go and hide in the skeletal muscle, it goes and hides in the lung. Okay, okay. Again, which organism produces this clinical image? I need more information regarding this, guys, because I believe that this was more of a clinical question, or had they directly given this image and asked you that which organism is causing this? So please just help me out here. Okay, guys, I got the skeletal muscle option. Still, it's not the answer, guys. So please, aage badho. Tell me, help me out with this question. Did they just give you this image and ask you that which organism is causing this clinical image, or was there more history related to this? Because I believe that they can't ask such a simple question. That was all that was asked. It was so direct. Then we know that this is colpitis macularis, or in the other words, what we call as the strawberry cervix, है ना? So we know that this is something which is seen in just one organism, that is your Trichomonas vaginalis. Very, very direct. One line question, amazing. Organism was not the option, ma'am. It was what causes this. Okay. Okay, I think it means the same. Okay, bacterial vaginosis was one. Only image, ma'am, no history. ठीक है. And fourth was CA cervix. ठीक है, great. Then we all know that this is called Colpitis macularis. Even if which organism was not given, if they're just asked that what is the whatever, no history, ठीक है. ठीक है, done, guys. Trichomonas vaginalis. Okay, this you help me out, guys, because the answer is simple, but I need to know that if this was the image that they had given, was this the kind of image? Because people were saying, ma'am, it was some toxin that was acting on the elongation factor 2, right? So this is what was acting on the elongation factor 2. But had they given something like, this kind of an image, or was the image different? Because somebody said that an image was given and you had to kind of decide the incorrect statement about the organism that is shown in the image. So the organism here, which is acting on elongation factor 2, we know that there are only two. One is your exotoxin of Pseudomonas, right? But exotoxin of Pseudomonas, and another one is going to be your diphtheria toxin. So, similar image are related to elongation factor. So these are the two organisms that do it. We already know, always read it in the mission classes also. So if this was there, and I'm going to go with diphtheria because based on the options, I'm looking at diphtheria more. So we have to find the incorrect statement. Is it phage coded, this diphtheria toxin? Yes, we know that beta Coraini phage is the one that transmits this tox gene. So it is true. Produces exotoxin. Yes, diphtheria toxin is an exotoxin, causes myocarditis. It is a rare but a complication of diphtheria. Most toxic organism known to man? No, this is an incorrect statement. So for me, option D is going to be incorrect statement. AB subunits, guys, here AB subunit present. Most lethal toxin thiya tha. ठीक है. If it was given most lethal also, then also it's wrong. We know that is your botulinum. So it is not. Ribosomal inhibition tha, guys. Don't change the complete topic. Ribosomal 60th ribosomal inhibition tha, then we are completely on a different track. Now we have to think about Shigella. So ribosomal inhibition, Shivangi, please confirm with me. I think everybody has told me about elongation factor 2. So I'm going to go with elongation factor 2. ठीक है? चलो. So the answer is going to be most lethal hai, or whatever it is, most toxic organism. Okay, another question that came, a patient had cough and fever, then sputum sample was inoculated on sheep blood agar that grew pinpoint alpha hemolytic colonies. Okay, gram stain is provided to you, and what is the correct statement about this organism? So given the image, okay, elongation factor 2 ho gaya, guys. ठीक है, guys. Arnav tak I have read the question, the options. So we have done with that. आगे बढ़ो. So this was given. I think this is the kind of image. It is a gram-positive cocci in pairs. And given the whole history with the alpha hemolytic colonies, pinpoint agar, cough and fever, I'm going towards the diagnosis of Streptococcus pneumoniae infection, right? Yes. So, what is the correct statement about this organism? I believe they had asked about the correct statement. So, when we talk about streptococcus, none of the streptococcus are catalase positive, they are negative. So, vancomycin is the drug of choice. No, for streptococcus, the penicillin is the drug of choice if it is susceptible. Bile soluble, yes. Streptococcus pneumoniae is bile soluble. Remember that mnemonic of bile soluble tha, inulin, fermenter, and optochin sensitive. So these were all the options. Yeah, these were all the things that was there related to Streptococcus pneumoniae. Vaccine is not available. Again, wrong. Vaccine is available for Streptococcus, the pneumococcal vaccine. Optochin was in the option. So if optochin was in the option, were they 5 options and had they given it as a sensitive or a resistant thing? HSV? Guys, where was HSV? Herpes simplex, Aman, what are you saying? HSV? If they had asked the correct statement, it is bile solubility, it is bile soluble. If optochin was given, then where was optochin given, guys? One of the options have to go. Then 5 options, were there 5 options? Then if there was not 5 options, then where was optochin, guys? Because optochin is also done for this, and I believe then they would have given optochin resistant. Okay, now somebody saying, ma'am, bile was given. No, optochin was given. Okay, guys, you can fight over this, but please give me later a correct no optochin. Catalase negative. Okay, if it was catalase negative, bile soluble only. Guys, I'm going to stick with bile solubility. Moving on. A healthcare worker had a needle prick injury from a patient who had viral load and HBs antigen positive. HCV had 2 complete schedules of vaccinations, but a non-responder. So what is the next step in this case? I believe this was the... Okay, guys, I've moved on to the next question. Bile was given for sure. The bile solubility is the answer. Catalase negative tha option mein. Catalase negative tha option mein, guys. I don't think it can be catalase negative. It has to be catalase positive, guys. Because negative mein to fir, then that is also a correct statement. It can't be. Either it has to be multiple correct then. Was it like a multiple correct option thing, guys? Because somebody is saying all options correct. Okay, I'm going to move on. Healthcare worker, needle prick injury, patient had high viral load, HBs positive. Healthcare worker had 2 completed schedules of vaccinations, but a non-responder. So here, what do you do? I think this was the option. So if it is a non-responder person after 2 full doses of vaccination, there is no point giving a vaccine to this person because he will still not respond, right? And just 2 doses, stat is not the criteria. The criteria is that 2 doses, one right now and one maybe 2 weeks later or 4 weeks later. He took 3 months ago. Option B was 2 doses now and 1 after 4 weeks. Okay, this is what I wanted to confirm. No booster for option. No option for booster. To booster you can't give anyway. The person is a non-responder. No matter how many more vaccinations you will give, the body will not make antibodies. 1 dose, then full dose of vaccine. Okay, you are saying booster nahi tha. 1 dose HBIG and then 1 full dose of vaccine. Again, not the correct answer, guys. Vaccine is not going to help this patient. We have to give only immunoglobulin. HBN first dose of vaccine same day. Again, can't give vaccine, guys. No, we can't complete the vaccination. Person is not going to respond. He's a non-responder. Was this word given in the question or not? Was this given in the question or not? If this is given in the question that the person is a non-responder, then kitna vaccine doge, he will still not respond. Uski body is not willing to make antibodies. Okay, so my answer is going to be B. उसने लगाया नहीं third dose. Was the word non-responder given? If they are saying that third dose was not put, not taken, if that is the thing, then I'm going to go with the first dose and this 1 dose of HBIG and then 1 dose of full dose of vaccine. Okay, guys, non-responder was there. If non-responder is there, then my answer remains B. I'm going to move forward. What is the most common cause of adult gastroenteritis? Okay, this was a very weird question because abhi tak they used to always ask about the child ka gastroenteritis, right? And we all know that adeno, rota, and your astrovirus, they are all the one that causes some kind of gastroenteritis in children, right? Either infants or babies. So apart from that, the only one that is causing it in adults is going to be the norovirus. So our answer was option number D. आपने बोला था एक डोज देना है नॉन रिस्पॉन्डर को guys एक डोज after first time that the person has had a complete dose of vaccination. Mukesh, what I said was that if a person has completed one full dose of vaccination, that means 3 doses. After that, if the person is not responding, you give another dose. But here they have written that 2 full doses of vaccination was taken, like 2 full cycles of vaccination was taken. If 2 full cycles are taken and still the person is not responding, then that person is called as a non-responder. For that, we just give immunoglobulin. We don't give vaccine because it's not going to help now. So full 2, they had written 2 schedules of vaccine. That means total 6 doses was given to this person. Okay? Yes, 2 schedules in the past. Got it. So norovirus is the answer. It is the most common one which is causing gastroenteritis in adults. So even if you didn't know this norovirus, you know that adeno, rota, and astro cause problems in children. So the answer by exclusion had to be norovirus. Okay, guys, now 2 things that I did not get the complete question for. First, was there a question on how is innate immunity different from acquired immunity? Was this the question, or had they asked something related to the innate immunity? Because this is something where I saw somewhere, but guys, just help me with this question. Guys, if there was non-responder in the question, the answer is going to be immunoglobulin giving, no vaccine, please. Why is innate faster? How is innate faster? Had they given this? Why is it? Yes, same question. Tha. Okay, now give me the options then. How is it different? It does not generate memory. Why is innate faster was a separate question. Innate immunity is against most common pathogen. Against most common pathogen. Okay. Guys, are they these 2 different questions or are they the same question? I'm getting confused now. Baba Adeno, Amar Adeno 4041, remember it is gastroenteritis in children. Identify self and non-self. Okay, identify self and non-self. Okay, somebody saying can't differentiate between self and non-self. Somebody saying identify self and non-self. Guys, you're confusing me now. It has common receptors to act fast for broad coverage. Common receptors to act fast for broad coverage. Innate versus adaptive. Okay. Okay, I'll have to basically doesn't undergo negative selection. Germ cell lines. I'm just writing, guys. I'm not basically trying to figure out what was there. Okay. How is any different from acquired? Okay, I'll figure this question out, guys. I need one more help. Something about HPV image. Was there an image of different layers of the cervix or something, and they had asked you something about HPV? Acquired. Negative selection option was not there. Okay, it doesn't undergo negative selection. Generate memory. Okay, it does generate memory. Guys, I'll figure this question out, but please try to help me with this. Was there something related to HPV image? something related to some layers of the cervix or something, and then in the answer options there was HPV. Different layers of skin was there. Okay, so skin ka layers was there. Viral application. Okay, I think then I will leave this, and this might be taken up by either Rena ma'am, or this will be taken up by no skin layers were given. Acha, theek hai. So this will be taken up by Madhudeni sir then. ठीक है. So guys, I am done here. Thank you. If you have any more questions, then please send me on the WhatsApp or Telegram or anything. And okay, I'll hand it over to the next person. Okay. Thank you, sir.
Thank you, ma'am. Thank you. Hello, dear students. Hope audio and everything is okay. Hope your exam, all the things are in a good way. So anatomy questions, yes, most of the questions were easy, but few questions were very tricky, and 1-2 questions are totally new in pattern. So can we start? Please inform me that audio and everything is okay. Yes. So we are going to look the changing pattern. Yes, almost the pattern is same, but little bit few questions are deviated. So this is the session on the basis of the recall question, and options may be different. Please suggest any kind of a correction. So analysis, till now I got total pure anatomy question 11. Yes, definitely if you will integrate, then you will get the more and more questions, because anatomy is the basic subject and all the subjects are arising from the anatomy. Yes, Mr. Sai, study, everything is okay. No? Yes, dhak, male life healthy. So this time, general anatomy, no question. Generally, the one question from the joint is definitely asked from the in our INI-CET, but this time no question from the general anatomy. Head, neck, and the face 5, and neuroanatomy 2. So total 7 question. So can you see 7 by 11 question? So for the INI-CET, it is clear cut during our session, during our any kind of session, in the videos as well as in our regular session, in the marathon session, in our mission classes, I always told you, for the INI-CET we have to mainly focus for the, yes, head, neck, and the neuroanatomy portion. You can see among the 11, total 7 question had been asked. Yes, surprisingly this time I am not getting any question from the upper limb. If you got any question, yes, any question from the upper limb, please inform me. No question from the thorax, no question from the abdomen. Okay, lower limb, one question. Gluteal region, as I told you in the 10 questions also, that gluteal region definitely it will be asked. This time gluteus maximus, again it had been asked. INI-CET is famous to repeat the topics. This time again they proved. Pelvis, yes, one question only. Embryology, again they asked the pharyngeal arch artery. And histology, one question from the gland, but this time they given the lots of the question. Okay, so okay, Joshna, you are saying nerve injury, okay, sign. One question from the upper limb, that is the okay sign. Thank you, Joshna. So now look here. Okay, shoulder dislocation also, so I am adding the shoulder dislocation. You can get this topic in the orthopedics also, no? Okay, fine. So we are going to discuss about the head and neck question. So look here, which bone is attached with the marked area? So they given the ring shaped structure. Yes, we had seen many times during our classes with the 3-dimensional orientation, cadaveric images also. So this is our beautiful 3-dimensional orientation. During the class I inform you, sir, this is the our skull. Yes, you can see the first bone, lal full, neela full, anatomy beautiful. Sir, this is the first bone, atlas, and it is clear cut, getting articulation with the our, yes, occipital bone. This is the atlanto-occipital joint, which is responsible for the yes movement, while the atlanto-axial joint is responsible for the rotatory movement. That is a pivot joint, which is the no movement. So hope you all did correct this question. It is easy question. Answer was the occipital bone. Any change in the option temporal bone, occipital bone, axis, or sphenoid bone? Please inform me, dear students. Yes. Now come to the next question. Again, INI-CET, famous for the muscles of mastication. Again, they proved. Okay, INI-CET is famous to repeat the topics. A patient presented with the difficulty in opening the jaw, but not in closing. Which statement is false about the involved muscle? So definitely, which muscle is the opener of the jaw? So only depressor is the lateral pterygoid. I told you the formula for the action of the lateral pterygoid. Delhi Public School. Yes, lateral pterygoid is responsible for the depression. Yes, it is the protractor, and it is responsible for the side to side movement. Okay, So now try to catch. Yes, lateral pterygoid is very favorite. Yes, Khushunuma, you're right. So during our classes, I had shown you all the muscles of mastication, and this is our lateral pterygoid muscle. Can you see? Sir, this is our lateral pterygoid plate, and this is lateral pterygoid muscle, which is getting insertion in the pterygoid fovea, which is very close to the temporomandibular joint. Very clear question we discussed during our mission classes in our regular video all. So it is attached near the temporomandibular joint. Yes, it is right. They are asking the false. It is supplied to the mandibular nerve. Definitely all muscles of mastication, they are derivative of the first arch, and the first arch nerve is the mandibular nerve. And apply the Hilton law, जो नदी जहां रहती है जहां बहती है उसे सप्लाई करती है. So definitely it is supplied with the mandibular nerve, right? Depresses the mandible while mouth opening. Definitely it is a depressor, so it is also right. Attached to the medial pterygoid plate? No. I had shown you right now the three-dimensional orientation. Sir, it is not attached to the, yes, medial pterygoid plate. You can see this is the lateral pterygoid plate, that is the medial pterygoid plate. It is not attached to the medial pterygoid plate, but it is attached to the lateral pterygoid plate. हाथ कंगन को आरसी क्या, पढ़े लिखे को फारसी क्या. Yes, we had seen all the cadaveric images in three-dimensional orientation. Hope you all did write this question, na? Yes, okay, Khushnuमा, DPS is sahi hua na? Very nice. Now again, during the classes, I told you also the 10 topics I given. That definitely one question from the cranial foramen. Cranial nose, one question is going to ask. So this time, nose supplying to the muscles of mastication passes through which foramen? So they asked, they marked, yes, muscles of mastication. Right now I told you, again, it is a topic of the pharyngeal apparatus. Yes, muscles of mastication. Here, this is our first arch. And first arch, which nerve is flowing here? Again, Hilton law. जो nerve जहां रहती है, जहां बहती है, उसे एक supply करती है. So answer is the mandibular nerve. And we know very well, the mandibular nerve, it passes through the foramen oval. The formula, the very famous formula from the first MBBS, M for mandibular nerve, A for accessory meningeal artery, L for lesser pectoral nerve, and E for emissary vein. Now we have to identify where it is passing. So I told you the formula to identify the difficult foramen. बीचों बीच में कौन रहता है? King. Okay, राजा. राजा के दोनों तरफ कौन रहती है? रानियां. यस, क्वींस. क्वींस आर शाई इन नेचर. यस, फोरामेन लेशरम. राजा रानी को रोज देता है, ROSE. यस, और यहां पर हमने एक नॉनवेज जोक भी मारा था, राजा रानी को रोज देता है, रोज देता है नहीं कहा था. ओके, सो कैन यू रिकॉल हमारे हॉलीवुड बॉलीवुड टॉलीवुड इंटीग्रेशन और जोक से क्वेश्चन आए. सो यू कैन से सर दिस द फोरामेन रोटंडम, सर दिस द फोरामेन oval. Yes, and this is the foramen spinosum from where the emissary vein may pass, may not pass. So this was the answer, foramen oval. Yes, yes, Mohsin, hope you did correct. King queen को rose देते हैं. Yes, perfect. Mohsin, you did right. So answer in this question is the foramen oval. Any change in this question? Yes, foramen was marked. Aman, you are right, better. Hope you all are getting the point. Yes, yes, yes. हाँ, रोज देता है नहीं, रोज देता है, ये हमारा फनी निमोनिक था. Now come to the next. All of the following structures are related with dysphagia except. Okay, so this is the question integrated with the ENT as well as you can say the medicine also. Okay, so related with the dysphagia. Dysphagia, yes, for the proper our mastication, for the proper our swallowing. Yes, the palatopharyngeus muscle of the pharynx is responsible. Yes, stylopharyngeus, it is also the muscle of the pharynx. Yes, pharyngeal constrictor, we studied this all the muscles in our pharyngeal apparatus part, muscles of the pharynx. Also it is a topic of the ENT. But the tensor veli palatini, it is related with the palate. Palate is not participating in the our swallowing activity. So answer is D. Yes, any correction in this question, better? Okay, image was given. Okay, image, I will add image. Okay, image, no? Okay, a cadaveric image or animated image. Dysphagia and dysarthria. Dysarthria. Okay, beta. Okay, thank you so much. Okay, image with A, B, C, D. Okay, I will make more, I will add the more things. No, okay, thank you, thank you. So this was the cadaveric image. This was the cadaveric image. Okay, thank you, Khushi. Thank you, beta. Okay, fine. Only image. Now, can you help me in this question? Cranial nerves pass through which of the following bone? This time they disarticulated the bone. So they given the temporal bone. Yes, they given the maxilla bone, and they given the, yes, sphenoid bone, and one more bone. Can you help me? कोई बात नहीं खुशनुमा. ग्लॉसस मसल था इमेज में. ओके, आई विल सी. Webhogen, CNS. Okay, cranial nose, CNS. So just to see, I'm not getting exactly the question, and one image is also missing. Okay, but I'm trying for it. Okay, look here, which cranial node is passing? So now try to understand. Temporal bone is passing the facial nerve. Maxillary nerve, it is passing the our foramen rotundum. It is coming as the infraorbital nerve, and this is our sphenoid bone. Yes, can you see this is the superior orbital fissure? Three-dimensional orientation we had seen, na? So during the class, we had seen our proper three-dimensional orientation. Yes. And at that time, I had shown you this image again. Two questions from here. So this is the view. This is the view. Okay. So here is our superior orbital fissure. So the same image was given. And we know from the superior orbital fissure, sir, third nerve, sir, fourth nerve, sir, sixth nerve, also the fifth nerve. Many cranial nerves are passing. So I don't know what was the exact question, and one image is also missing. But this is not bone may be the answer. Okay, yes, Kshitiz, nerve from CNS pass through which of this foramen? Fine. Okay, but it may be the answer. I will find. Can you help me more? Fourth image was cranial fossa with cribriform plate. Okay, Abhinav, thank you, beta. Cribriform plate. Okay, so maximum nerves are related with this sphenoid, third, fourth, sixth. So you can go with that one. Otherwise, cribriform plate, again, the first cranial nerve is related here, na? First cranial nerve is related here. Temporal bone, it is related with the seventh nerve. Yes, maxillary nerve, it is passing the foramen rotundum. It is coming out through the infraorbital foramen. Okay, so all are passing any branch. But if any one answer, so maximum nerves with the sphenoid. So sphenoid may be the answer. Zygomatic bone was given. Okay, I'm writing the zygomatic bone also. Okay, so I have to see for the zygomatic bone. Okay, वन ऑफ द नर्व पास होती है जो सेंट्रल नर्व सिस्टम को बिलोंग करे, विच स्कल बोन पार्ट्स से एटलीस्ट वन ऑफ द नर्व पास होती है जो क्रेनियल नर्व सिस्टम को बिलोंग करे. ओके, अगर ऐसा हो तो बेटा क्रिबिफॉर्म प्लेट भी हो सकती है. I will see, no? Okay, I'm moving for the neuroanatomy. So in the neuroanatomy, yes, they given the, yes, the brain stem, dorsal view. Do you remember during our regular class, we discussed about this all? Sir, floor of the fourth ventricle. Sir, there is the stria terminalis. Yes, this is the floor of the fourth ventricle. Here is the facial colliculus. Yes, superior colliculus, inferior colliculus. And this time they focus for the superior cerebral peduncle, middle cerebral peduncle, and inferior cerebral peduncle. During the magic of the cerebellum, 1, 2, 3, 4, 5 of the cerebellum, I taught you the cerebral peduncle. So this is the area of the superior cerebral peduncle. Here is the area of the middle cerebral peduncle, and here is the area of the inferior cerebral peduncle. So they marked. Okay, I'm not getting the exact marking what they did, but students were saying about the inferior colliculus was correctly marked. Okay, or I'm not getting exactly the marking. There was the A, B, C, D, something like that. Okay, so but this kind of the question was there. I will make the more perfection in this question and the wording and the correct image, and then I will inform you better. Okay, yes, yes, Khushi. Now there was the one question: which lobe is involved in the visual tracking or scanning? Match the following. Okay, this was the match the following type of the question, na? Okay, which lobe is involved in the visual tracking or scanning? So can you tell me such kind of question was there? Okay, scanning. Okay, see here, visual tracking. If they are asking about the visual tracking, then you can go with the occipital lobe, na? But if they are asking about the scanning, so you know when we read, our eyes are following the same direction, left to right. और हमने एक यहाँ पर जोक मारा था क्या कि अगर मुझे जल्दी पढ़ना है तो लेफ्ट आई तो लेफ्ट से पढ़, राइट आई तो राइट से पढ़, ऐसा नहीं होता. ओके, सो इफ दे आर आस्किंग अबाउट द स्कैनिंग मीन्स कॉन्जुगेटेड saccadic movement which is controlled by the frontal eye field area. Yes, this is the area number 8. So in that condition you have to go for the area number 8. So we have to look for the options. Okay, if they are asking for the visual tracking, then go for the, yes, occipital lobe. But for the scanning, then if the frontal eye field is given, yes, then you have to go for the area number 8, na? Can you inform me? Occipital. So see here, if visual tracking is given visual pathway, then you can go with the occipital, na? and I have to look for the other the options ना, what was the option, what was the exact. I'm not sure about the correct answer right now ना. स्कैनिंग पूछा था, ओके स्कैनिंग पूछा था, स्कैनिंग पूछा था तो फिर कॉन्जुगेटेड साइकेटिक मूवमेंट की तरफ जाना पड़ेगा, एंड इफ द फ्रंटल आई फील्ड फ्रंटल लोब इज गिवन देन यू हैव टू गो फॉर द फ्रंटल लोब ना. ओके, वी विल सी नाउ अपर लिम्ब. Right now the students are saying okay sign and shoulder dislocation. Can you inform me beta what was the question? Okay, स्कैन पक्का था तो बेटा फ्रंटल लोब की तरफ जाओ, वो ज्यादा अच्छा. फ्रंटल लोब was given in the option, frontal eye field area. Okay, yes, congratulations Virat, nice attempt. Scanning, okay, fine. Now okay sign, septum pellucidum diagram. Okay, this is the new मुकेश, आप क्या बोल रहे हो बेटा? सेप्टम पेलुसिडम का डायग्राम क्या था? ये नया क्वेश्चन, ये किसी ने मुझे नहीं बताया क्या था ये क्वेश्चन. Okay, yes, shoulder dislocation x-ray. So this question will go to the your orthopedics as well as the radiology, no? Okay sign, which nerve? So anterior introosseous nerve. Anterior introosseous nerve was given. Okay sign, anterior introosseous nerve. Discussion close. Okay. Septum pellucidum divides the, yes, septum pellucidum divides the two lateral ventricle. Septum pellucidum divides the two lateral ventricles. Yes, it is making the wall of the lateral ventricle. It was image based question, one liner question. Septum pellucidum is related with the lateral ventricle. It is in between the two lateral ventricle. Median nerve, okay. If this is the best answer, if it is not given, then median nerve is the answer. Yes, CSF mnemonic, definitely. Vivogen, CSF, THP, MPN. Okay, so this was not given, so median nerve was given, so you will go with the median nerve. Okay, okay, thank you, Manish. Now, lower limb, one question. Always, during the class, always I was saying, INI-CET people, they love the gluteal region. They love the gluteal region. Always, you will see the INI-CET 2021, 22, 23, 24, 25. Always you will see either the gluteus medius minimus or the maximus. Two times they ask the gluteus maximus. So muscle responsible for the VP extension, definitely the gluteus maximus, and it is also causing the knee extension via the, you can say, iliotibial tract. Yes, there is the one iliotibial tract. Catch this one, sir. There is the iliotibial tract. So during our three-dimensional orientation, I was showing this iliotibial tract. Can you see, sir? This gluteus maximus muscle. This is the gluteus maximus muscle. This is the chief extensor. Where muscle goes, there movement flows. The third Escavian rule. Yes, it is backside, so it is causing extension. Okay, fine. Our third magic, and then it is getting insertion into the our gluteal tuberosity, but it's three-fourth fibers are also getting insertion into the, yes, this iliotibial tract. This is extending from the ilium, and then it is going to the tibia. It is going to the tibia. Are you getting? It is going to the tibia. You can see iliotibial tract. So it is crossing the knee joint from the front. So it is also participating in the extension. It is not the chief extensor, but it is helping in extension. It is helping in extension. Getting the point? So among the given option, this is arising from the iliac crest. Yes, sir. This gluteus maximus is taking origin from the iliac crest. Tell me, beta, if any correction is needed. So answer is the iliac crest. As originally of the, yes, they ask about the origin of the, and this is the repeated question. It was asked in the May 2025. That's why always we say that INI-CET is famous to repeat the topics. One more question there is, which not attached to the iliac spine. Yes, we are coming, Pamisha, we are coming for that question also. Now the thorax, no question. Yes, abdomen, no question. Please inform me if any question was there. Now pelvis, मार्क किया था ABCD. ओके, तो इसमें मार्क ABCD मीन्स इट वाज इमेज बेस्ड क्वेश्चन ना. ओके, ओके, फाइन. Yes. Now look here, pelvis. Which of the following? This is the question from our UG time. Now, do you remember with the ischial spine, the PIN, pin is related. And when I teach to the student, then I tell them Pinto, Albert Pinto को गुस्सा क्यों आता है? Yes, P for pudendal nerve, I for internal pudendal vessels, N for nerve tube, obturator internus, and T for tendon of obturator internus. Yes, in your textbook the mnemonic is given, that is the pin, but we added here the TO also, pinto. These are the structure. So pudendal nerve, internal pudendal vessels, they given the only pudendal vessels. You have to understand that they are asking about the internal pudendal vessels. Okay, now ischiococccygeus, yes, it is the pelvic diaphragm topic. Do you remember I taught you the pubococccygeus plus iliococccygeus plus ischiococccygeus is equal to pelvic diaphragm. So this ischiococccygeus is also related, but tendon of the obturator externus, आखिरी वर्ड में ये खेल गए, आखिरी वर्ड में खेल गए. They are not giving the obturator internus, they given the obturator, they are not giving the obturator internus, na, they given the obturator externus. So in this question answer is the 4. iliac crest इमेज में लेबल नहीं था. ओके, तो क्या था बेटा, ऐसा इससे रिलेटेड कुछ था क्या? यस नॉरस बेटा, डॉक्टर एजे, यस प्लीज इन्फॉर्म फॉर दैट. हिस्टोलॉजी, हिस्टोलॉजी में एक क्वेश्चन था लेकिन उसमें 4 इमेज थे, एंड आई एम नॉट सक्सेसफुली गेटिंग व्हाट दे गिवन. हिस्टोलॉजी शोइंग द 4 glands, asking which one does not have endocrine function. Always I told you in the our every session, epithelium and gland you have to study. They ask this time the gland, uterus, spleen, pancreas, parotid, something like that. I am not getting exactly the image, no, till now. Students are very confused here, so I am not exactly getting. But histology one question. And last, embryology. Embryology was giving the again the pharyngeal apparatus and pharyngeal arch artery. So second arch artery, stapedial artery, hyoid artery, third arch artery, common carotid, internal carotid artery, fourth arch artery, supplementary artery in the arch of aorta on the, yes, this is on the right side and this is on the left side, and sixth arch artery, that is our pulmonary artery and ductus arteriosus. So we know exact framing is needed. So thank you very much. Kindly help in the correction of the wordings, recall of the other option. Thank you. So any kind of the doubt you can ask me at this ID, Dr. Shrikant Verma classes. Also you can message me at 913117 83495. Okay, any kind of the doubt, any kind of the correction, please inform me. Thank you, beta. Thank you. Good evening, ma'am.
Good evening, sir.
Please take the session. Thank
Yeah,
you.
sure. I'll just share my screen. Okay. Hi, everyone. So just give me a minute so that I can open up the YouTube and I can see your chat. Just give me a minute.
Please take the session. Thank
Yeah, sure. All right. So, am I audible, visible? Everything is fine, right? So we are going to go quickly throughout through the physiology, right? If any option seems to be different, you can just inform me. I'll definitely take a screenshot from my phone, right? And physiology, almost 14-15 question came, right? So let's see how it was. Thank you, Mukesh. All right, chalo. So first question was about Conn's syndrome. We have discussed that in detail. Conn's versus Addison. I have shown this, you can say the chart in every class. Even in the marathon we have discussed this, right? And what is the function of aldosterone, and we had made it easy. Right now you have to tell me whether it was the alkalosis or the hyponatremia. Some students said that, ma'am, there was no hypernatremia. Instead of hypernatremia there was hyponatremia, and acidosis ke bajaye there was alkalosis. Okay, all right, alkalosis was there, so it was hyponatremia and alkalosis. Then the answer will be hyponatremia, right? Let's move on to the next question. During normal inspiration, SBP, that is systolic blood pressure, or systemic arterial pressure, decreases slightly because of, we have discussed this in the main classes, right? What happens is inspiration, may I always tell you that there is a suction pressure. Suction pressure does what? It increases the compliance of the pulmonary system, and the pulmonary system compliance is increased. That means more blood is going to stay in the lungs, lesser blood will go towards the left ventricle. So decrease LV filling is going to be the answer over here, right? Now there are two options in which the students are getting confused. Decrease venous return, why not? Telegram pe this is the discussion. Please remember they have asked the cause, right? During the normal inspiration the SBPs decrease because of, right? So venous return, yes, it is decrease inside the RA, but that is not the reason of decrease in the SBP, because it is for the fraction of second, and And ultimately, later on, it can cause it. But right now, the better answer over here is decrease LV filling because of increase pulmonary compliance. All right. All right. Wonderful. I hope you got this correct. Okay. Acha, both were given. All right. Shall. So next is pressure volume curve of this left ventricle primarily affected by. I always tell you one thing, even in the marathon classes, if you remember, if the graph is going upward means after load is increased. After load is what? The load acting on the muscle, the muscles start to contract, and this is because of the peripheral resistance. Increase in the peripheral resistance, heart has to put a more work. Right now, why not the contractility? Contractility, if it is increased, please remember what is going to happen. If the contractility is increased, what is going to happen? Of course, the graph may go upward, but please remember that if the contractility is higher, the graph will shift towards the left hand side because the ESV is going to be decreased. More contractility means more force of contraction, more will be the stroke volume, lesser will be the end systolic volume, which is not the case over here. And that's why the answer cannot be increase in the contractility. If the venous return has been increased, I always tell you venous return increase means the graph will shift towards the right hand side. Why? Because it is going to increase the EDV. And aortic compliance, if the aortic compliance is increased, that means you have a lesser resistance in the front. So the graph should go down. Over here, the graph is going up, right? So please remember that. Anirban Mandal, please let me know what was it. Increased RA filling. Increased RA filling. Even increased RA filling cannot be the answer over here. See, even if it is increased RA filling, I agree that it may be possible, but immediately why the response? Because this is happening in the fractions of second, right? Increased RA filling cannot be the reason of decrease in SBP. Later on, it will rather increase the SBP, all right? So please remember, it cannot be the answer. The answer, why the SBP decreases? Because of the pulmonary increased in the suction pressure, increase in the pulmonary compliance, more blood will stay in the pulmonary system, less blood will come towards the LV. Okay, that is the reason. All right. Chalo. Nobel Prize. We are coming on to that. Serum magnesium levels are mainly maintained by. We have discussed this in a different manner. I told you paracellular transport of the magnesium. We have discussed that in the renal system, right? So mainly everything is regulated by renal system. Yes, calcium is regulated mainly by the bones, right? So please remember, it is not because of the bone, though everything contributes one or the some other way, but mainly it is because of the renal regulation. All right. So that is going to be the answer over here. Okay. Only pressure increases. Okay. Volume change nahi tha, pressure increase tha. Okay. Fine. Even if that is the case, then also the answer is going to be the peripheral resistance, right? After load is increased, that means you have to work against more resistance. Okay. All right. So I'm taking a screenshot of it. Whatever it is there, I'm missing it. That I'm changing. Okay. Nobel Prize. I'm coming on to that. All right. So, yeah, Nobel Prize 2025, it is for the peripheral immune tolerance mechanism. It is not for any other thing. So this is a factual based question. It goes to, or it went to Mary, Fred, and the Sakaguchi, right? Next question. Hypothalamic nucleus is primarily responsible for leptin resistance. Please remember, the leptin is released from POMC, that is the preopiomelanocortin neurons, and it is all going to act on this arcuate nucleus. But what happens is, if you continuously irritate something, what is going to happen? The down regulation of receptors occur, right? And this the same thing is going to happen in the obesity. Obesity, say, the fat tissue is going to be increased, and the fat tissue is the one which is going to release this leptin. We have discussed this. Leptin resistance is going to be there in the obesity, right? And what is going to happen? This leptin, more and more leptin continuously irritates this arcuate nucleus, and that causes down regulation of this arcuate nucleus receptors, right? So that is going to cause the leptin resistance, basically receptor down regulation. All right. Next question, which of the following has lowest sodium? I hope this question was there. Yes. Okay. Even if the lateral nucleus, instead of which lateral nucleus was there, Lakshmika, please help me out over here. Sanskar also, lateral nucleus which was not there, paraventricular nucleus tha beta, supraoptic tha kya? If lateral nucleus supraoptic nahi tha kya? Posterolateral भी था, which was not there then. 5 ऑप्शन तो नहीं हो सकते ना बेटा. Lateral nucleus. Okay, posterolateral. Fine. Akanksha saying my physiology rocked. Okay. Wonderful, Akanksha. I hope to see you in the interviews. All right. Chalo. So I hope supraoptic was not there. All right. Thank you. Thank you so much, Khushi. All right. Chalo. So I'll remove this. Okay. Chalo. Next. Which of the following has lowest sodium concentration? We have discussed this. Lowest sodium concentration is going to be in the colon, right? Sodium concentration is going to be lowest. Potassium concentration is going to be the highest over there, right? And we have discussed this in the factual based question. Why? Because sodium gets reabsorbed everywhere else, right? And in the colon, we are going to have the least sodium possible, right? So colon is mainly there for the water reabsorption, not for the any other things, okay? So that is going to be the answer. Now, this was the question which was there, right? And the options were right. कोई बात नहीं, खुशनुमा, it's okay. All right, chalo. So which of the following neurotransmitter is correctly matched? Lateral हमने पढ़ा था ना, it is for hunger and thirst center. How it can cause the leptin resistance, beta? है ना? चलो, कोई बात नहीं. Let's move on. Acetylcholine, basal ganglia releases, especially आपका pars compacta, right? And that is going to release the dopamine and not acetylcholine. Serotonin is for the raffinucleus. We have discussed that in the supraspinal pain mechanism. If you remember, raffinucleus से serotonin निकलता है, which is going to act on the interneurons, which is going to release the enkephalins. We have discussed that there. All right. I hope this was there. Okay. Akanksha incorrectly matched. इसमें पूछा था बेटा. Then I have to change the options. Please let me know, Akanksha. Options क्या क्या थे बेटा? What were the options? Because what options I got was this. Okay. चलो. Correctly match नहीं था. यहाँ पर incorrectly match था. All right. All right. So acetylcholine was nucleus. Basalis of Maynard. Is it? No. Locus coeruleus. Okay. This was locus coeruleus. All right. No, locus coeruleus releases norepinephrine. We have discussed that in the memory wala system, sleep wala system, sorry, sleep, okay? A, B, C, B, C, okay, okay. Chalo, incorrectly asked. So I'll tell you what is the correct thing over here, and I'll just take the screenshot of it and I'll, reframe the question. Serotonin will be released by raffinucleus. That is correct. Acetylcholine is by the nucleus basalis of Maynard. And you guys are telling this was given as locus coeruleus. Locus coeruleus, please remember, it releases norepinephrine. So if it is given in front of the acetylcholine, that is going to be the answer. If incorrectly asked, incorrectly matched was the question, that is going to be asked. Okay. And let's move on to the next question. Okay, ABD. All right. Thank you, Patel, Dr. Patel. I have taken a note of it. Definitely. All right. So thank you, Dr. K, INI-CET. All right. So myasthenia gravis में decremental response, we have discussed this many times. The answer is going to be decreased release of the acetylcholine. What happens is acetylcholine stores are going to be over as the person is going to utilize more of the acetylcholine to overcome the concentration of antibodies. We have discussed that in detail, right? And I told you the person is going to feel worse in the evening, better in the morning, because the acetylcholine stores are available. During the night, you are not going to utilize the acetylcholine, but as you wake up and start working of the patient of the myasthenia gravis, the acetylcholine stores will be decreased, and that is the reason. See, acetylcholine receptor numbers are not going to decrease. Number कैसे decrease होगा यार? Antibodies है, I agree, right? But number decrease नहीं होता है. The number will not be decreased. It's just that they will be blocked by the antibodies. But why they will be blocked? Because the acetylcholine concentration is going to be lower down. So if I have to choose better answer, the better answer is going to be acetylcholine. Otherwise, अगर receptor block हो गए, even if you give the acetylcholine from outside, that is not going to work now. If the acetylcholine receptors are gone, your treatment will not work. So that cannot be the answer, right? See what other teachers are telling, that is not my responsibility, right? तो treatment कैसे work करेगा बेटा अगर acetylcholine के receptors ही कम हो गए? So whatever acetylcholine you are giving from outside, that is also not going to work, right? So that is not there, right? So availability of receptor number नहीं था available. available of, low availability of the receptor. If that was the answer, it can be, right? You are saying no, reduced receptor of the acetylcholine per impulse. Reduce receptor per impulse bolo, kuch bhi bolo, reduce receptor are not going to be reduced. If I have to choose, I'll choose the decreased release of acetylcholine, or I can say decreased stores of the acetylcholine. Okay. Now, this was the question which was given. The oxidative phosphorylation of the ATP was shown, right? So, and then they have asked which is the, identify the transport mechanism. Basically, the sodium and potassium was shown. If this is the question and this type of diagram was given, it is again sodium potassium pump is shown, Nokia pump. We have discussed this, right? And configuration change is going to occur when you do the phosphorylation, right? Otherwise, how the sodium and potassium is going to be changed. All right. Now, please remember, this is going to be primary active. It is going to be pump, right? It is not going to be glut. Why? Because this is a passive transport. Ionic transporter, I have to, anion transporter, I need to know that whether it is the anion transporter hai to active hoga for sure, but sodium and potassium is given, none of them are anions, right? So this cannot be the answer. And sodium glucose chloride transporter, if you have to choose that, then I have to have the another transporter along with the sodium and potassium, which is not given. I hope this is correct. Okay. P glycoprotein. Pump in the option, sodium potassium pump. Okay, P glycoprotein was there in the option. Okay, pump was there in the option. All right. Only efflux was shown. Can you just DM me the diagram or image, because 2 images I got in the Telegram group, which was showing the sodium potassium pump, which was hinting towards the sodium potassium pump. Okay. Please let me know what was the image. Please DM me the image, right? And then we'll discuss it again. Okay. Sodium potassium nahi tha. Okay. So what was there in the option? देखो, अगर ऐसा कुछ दिया हुआ है तो पंप ऑप्शन होना चाहिए, right? The pump is going to be the answer. Okay. If not, please let me know what was the image. Okay. Then we'll discuss it. Okay, the PM, that is particulate matter 2.5, since pollution is going on, where it is going to act, this is going to be the dangerous one. Why? Because it's a so smallest micrometer, PM 2.5 micrometer is so small that it can go down towards the alveoli, right? And that is going to cause fibrosis. So the answer over here is going to be alveoli. Particulate matter 10, PM 10 is going to be the one which is going to be there in the trachea and bronchioles, not even in the nose, right? Nose may 10 say more than 10, nose may it is going to, we can say deposit, right? Then if it is between 2.5, 5 and 10, it is going to deposit in the trachea and bronchiole. And if it is less than that, 2.5, it is going to go in the alveoli, and that is why it is dangerous one. We have discussed this. FeV1 versus FVC ratio decrease kisme hota hai? It is going to be decrease in the old. We have discussed that multiple times, right? And मैंने आपको बोला था how to remember it, lesser than the distinction, that is less than 75%, right? Or 0.75. The answer over here is going to be 0.70. Okay. It's okay. ठीक है. चलो. No pump. Okay. Just give me. देखो pump वाले question का just give me the image, right? Or you can just draw the image by hand, right? We can modify that later. And please let me know what were the options. Okay. चलो. Crimson, I think you have given me the diagram. Okay, I'll check that. Okay, next question. ये वाला question था 50, 30, 40 was the answer. Okay. Then less than 50. 80, 50, 40, 30. Then I'll choose 80. If 80, 40, 30, 50, 30, 40, 30 was the option, then I'll choose 80. Okay. Mukesh Patel wasn't in the option. Okay. If this wasn't in the option and 80 was there in the option, then I'll choose the next base is going to be 80, right? If 50, 40, 30 is too less, right? The value below which, so I'll choose 80. Chalo. Next. Best indicator of adequate homeostasis with zero error. Zero error, we have seen that it is urine output. Rest of the things can change. And oxygen saturation, see, if the patient is stable, oxygen saturation is going to be stable, right? Or it may fluctuate if you change the atmospheric pressure of the oxygen also, right? So this is going to be the best, okay? Now tell me this. Vid is saying 50, 40, 30, 20. How come this can be the options, right? Then I'm going to choose the 50, okay? If 50, 40, 30, 20 was the option, then 50. All right, then I'll choose 50. Deepika and Sarv, okay. If 50, 40, 30, 20, तो 50 ही choose करना पड़ेगा ना? There is no other option, okay? Then I'll choose. SpO2 beta, SpO2 can change, right? SpO2 can change because of various reasons, all right? High altitude पे भी change हो सकता है, so that is not the best indicator. Which can vary, that is not the best indicator. Best indicator is going to be urine output. Urine output tells about overall all the systems, okay? So I'll choose this, okay? Next question, OGTT, ये वाला diagram दिया हुआ था. Now, all of you are saying that there were two, you can say graphs, which were going above the renal threshold, but one graph, see over here, is coming down later on. हो सकता है बहुत ज़्यादा शुगर खा ली हो and the insulin, this can be pre-diabetic, okay? So if I have to choose between this and this, yes, it is diabetic, but this is severely diabetic. So if I have to choose most appropriate, I'm going to choose the option A over here. Option A. This was the diagram. Let me know about question number 14. Let me know about question number 14. If this type of diagram was given and 2 hours pay, you can see at least the decrement is seen over here, but the decrement is not that steep and it is not coming out down, right? So this is going to be there. पूछा था DM कौन सा है? If A and B was the option, I will choose most appropriate. That is going to be A. Most appropriate is going to be A. Okay. So this is the diagram, moderate and severe, right? Moderate may at least it is coming down. If I have to choose one of them, I'll choose the A. Okay. Huntington Korea में क्या question था? I want the question from your answer. अच्छा, multiple choice था. Then तो you can choose A and B ना? Then तो you can choose A and B. Multiple option था. Okay. Multiple correct. Okay. You have to provide me the options of these questions. Okay. D कैसे हो सकता है बेटा? D तो normal है ना? See over here, as soon as you give the glucose, OGTT, what is happening? What is happening? This is the renal threshold ना? Renal threshold के नीचे है ना बेटा? So why the D will be the answer? D and C cannot be the answer because the glycosuria is not seen. It is below the renal threshold, right? Renal threshold के below है. That is not going to be the answer over here. Okay. Chalo, give me the answers. Okay. 300 cross कर रहा था. All right, which one was crossing 300? Let me know. Chalo, what you can do is you can just hand draw the diagrams and give me, right? I'll modify them as you have given me and give me the options because Apu sir is waiting, right? And let me know if Huntington Chorea was related to medicine or physiology. If it is related to physiology, please DM me the message, the question as well as the options, right? And we'll discuss the proper questions. Okay. So that is all from my side. Thank you very much, guys. Please DM me all the options and questions which we were not, appropriate. All right. So, good evening, sir.
Beautiful, Pooja. Well done. God bless you.
Thank you, sir. Thank you so
Best
much.
wishes to you. Your discussion was full of energy. As you're teaching always, have a great day.
Thank you, sir. Thank you,
Hi,
sir.
everybody. So let me share the screen. And thank you, Cerebellum, for this wonderful opportunity to interact with the students right in the evening. I hope all of you did well. All right. So I hope you can see my screen now. Is it visible? Am I good?
Yes, sir. Yes, sir.
Thank you very much, Shubham, and thank you for the entire team for working on a Sunday evening. And I know that it's going to be longer. Dr. Dilip, thank you for the opportunity. You squeezed me in, and I have I've got 5 minutes with you. The first question is, first decade, a child with FOOSH, fall on outstretched hand. All right. There is extension type of injury, supracondylar fracture humerus. The order of involvement in supracondylar humerus is anterior introitius, median, radial, ulnar nerve. All right. So AMRU, AMRU. All right. So when the anterior introitius nerve is involved, right, you can't do this wow sign or okay sign, also called as Keelow-Nevin sign. And this anterior interosseous is not in the options here. So you have to go with the median nerve. So FDP and FPL. These two, they do okay sign. And anterior introitius is not there. So you mark median. But if AIN is there, that's a better answer. That was question number 1. That came from that 70-minute session I've been requesting everybody. Patient with rheumatoid arthritis, which deformity is this? Right? Now, when you have this, you have to pick up which is the option here. Most of the fingers here, most of the students say this was the image. Our team also has collected this image. Right? Now you have got flexion of the proximal interphalangeal joint and hyperextension of DIP. Okay? So here you will mark this as the Botanier deformity. Absolutely correct, Rohit. Your answer is correct. All right? So you will go with Botanier deformity. All right? Coming to the third question. 60-year-old with generalized bone pain and easy fatigability. There is diffuse osteoporosis. Now, remember this. There are 3 osteoporosis that we always say. Patchy osteopenia, Sudex dystrophy. Disuse osteoporosis, right? Disuse is tuberculosis. Diffuse osteoporosis is hyperparathyroidism. There are only 2 conditions in which there is high calcium, hypercalcemia. One is primary hyperparathyroidism, and the second is multiple myeloma. I've been telling this. Now here it is parathyroid adenoma as a diagnosis, which is the commonest cause of primary hyperparathyroidism. That is why system AB scan. Come on, hearts for those who got this correct. Come on, my friends. Did you get this correct? Nice. 13-year-old boy has a waxing, waning, right? Pain and swelling over the mid shaft of humerus. You are second about, right? Second about the second decade of life. System AB is better. Now, second decade of life, mid shaft, second decade mid shaft. So you're talking about second decade diaphyseal lesion. Periosteal reaction suggestive of medullary involvement. अब यहाँ पर game घुमा दिया. What is the next best diagnostic investigation? You know, next best. क्या था question में? Was it next? What is best? Or was it next best? बताइए जी. So orthopedics, X-ray is the first investigation. MRI is the next investigation. Biopsy is the best investigation. अब question है next best. All right? So देखते हैं. अगर next था तो MRI होगा. Next is MRI. If it is best, then the biopsy. अगर confuse करके next best लिखा है, so this just means next. So MRI. So answer is MRI. Practically, it's going to be an MRI. All right? It's going to be an MRI. All right? Next. A 30-year-old man presents with history of fall. Right? He has severe shoulder pain and inability to move. Abduction, external rotation of upper limb, anterior shoulder dislocation. Of lower limb after trauma, anterior hip dislocation. Down, the head is down and arm is out. So down and out. What is down and out? Come on. Down and out. Down and out. Anterior dislocation. Beautiful. So down and out, anterior shoulder dislocation. This is what you should remember. Right? And the last one, match the following. Come on. This is what we did. Cave. So cavus kya hai? What is cave? Cavus. Increased plantar arch. Cavus is increased plantar arch. Opposite of cavus is planus, flat foot. Equinus, plantar flexion. Calcaneus, dorsiflexion. So when I look at this, equinus is plantar falcus. Calcaneus is dorsiflexion. Planus is flat foot. Cavus is increased arch. All right, my friends. So these are the questions from orthopedics. All right. So do let me know if there is anything you wish to ask here. So exaggerated plantar arch is cavus. You have done your best, right? And now you have to surrender to God for the good, great result you will have. Let's expect a wonderful, wonderful result, and let's organize a wonderful, right? Yes, wonderful, wonderful meeting in Cerebellum. All the very best, and let's get back to our dear Dilip sir, who's next in the waiting, right? To rock the stage, just like his wonderful personality. And Dilip sir, I actually overlapped two of your questions, Bowden-Meyer deformity and
problem, sir.
diffuse osteoporosis. That's
No
only
problem
going
at all,
to
sir.
help you out. And you are looking as bright as ever, right? And I hope all good with the family.
All well,
And
sir.
now you can continue with the Cerebellum family, the YouTube channel, and have a great, great session. All the very best, all of you. Love you all. Thank you very much, the organizing team. And thank you, Mukta. Thank you, Shimam. And everybody else who's working behind the scenes. Thank you very much. Have a good day. Bye, sir.
Hi, guys. Hope you have done well in your exam. Honest truth is, I don't want to really confuse you much today with medicine questions because, like, even we are not like quite sure about the options. Thank you so much, guys. Thank you so much, and hope you all have done your exams well. And I have a couple of, in fact, like 15, 20 questions I have collected. But the issue here is the options again. I don't know, like discussing the options right now is going to be the best deal or what, because it's not even like 5-6 hours since the exam got over. And it's going to be quite confusing. So that's why I thought like probably I can just discuss some of the questions with you and get the options alone to some extent. Okay. So let me tell the question so that you can share what is the probable options. I don't know, because like there have been quite a lot of confusions when it comes to medicine. Okay, I think you are able to see the screen. So one of the questions were on Conn syndrome. That was a quite easy question, I believe. So they asked like which of the following is incorrect. So I think that is supposed to be your hypernatremia. A similar question we have discussed in our ENDs also. Is that right? There was a question on Conn syndrome, a hyperaldosteronism question, which was primary. And the false answer was hypernatremia. So because you see hyponatremia, you see alkalosis. So not hyponatremia, you see like I don't know what was the option in that. So it was related to either hyponatremia or hypernatremia. So there was something like that. Okay. So that one was the question. And there was a question on tall P wave, yes. So that's an easy one. So you're going to see in tricuspid stenosis, because tall P wave is a sign of right atrial enlargement. Hypokalemia, alkalosis, hypernatremia, and hypertension. Okay, so what you're not going to see is hypernatremia, correct? Yeah. So that was the right answer. Hypernatremia is not a finding in Conn syndrome. Usually we don't see that. So otherwise we do see hypertension, we do see alkalosis, and we do see hypokalemia. Okay, you want to increase the font size? All right, no problem. So I'm increasing to 20. Okay, all right. So there was a question on HUGMA. So what are the things that are seen? So what are these multiple correct options? Multiple correct answers, I think. So you do see HUGMA in patients with DK. You do see HUGMA in patients with starvation, but I don't think you're going to see HUGMA in patients with vomiting. Vomiting is incorrect. So vomiting is going to produce alkalosis, right? Vomiting is going to produce alkalosis, not acidosis. So I think the answer for this is these two are right answers, DK and starvation, right? So So let me check. Is there any other question that we have got? Just hold on. And I think, was there a question on Cushing syndrome? Was there a question on Cushing syndrome, by the way? I don't know. Like people said, like there was a question on Cushing syndrome. So like Conn syndrome. I'm not sure about that. All right. So what is the site of leptin resistance? There was a question. We discussed that in endocrine. So under obesity, I've shown a diagram also. There was a site of leptin resistance is basically the arcuate nucleus, right? Arcuate nucleus. So where you have the leptin receptors. Leptin receptors. These receptors are also called as the OBRB receptors. Those are the leptin receptors. I think the leptin receptors were there in the arcuate nucleus. So usually the site of leptin resistance is supposed to be the arcuate nucleus. So that's the right answer for this question. All right. And apart from that, there was a question on high output cardiac failure. I think there was a different mechanism. They asked about heart failure. So whether it is anemia, fever, sepsis, or maybe thyrotoxicosis, all these have similar mechanisms. That is high output cardiac failure, high output heart failure, but not due to salt intake. High salt is going to result in volume overload state. Volume overload. So this is the one thing that's the odd man out. So that's not the mechanism for heart failure, right? So all of them, anemia, fever, as well as thyrotoxicosis, all of them have a common mechanism. So high salt diet is the odd man out. Okay. And you want to ask about Cushing syndrome. I don't know what question was on Cushing syndrome. People are telling there are 2 questions. So can you elaborate the options? Because I couldn't get the options in the group. So what are the options? So there were with regards to low DEXA, high DEXA, ACTH or high DEXA option. I don't know what do you mean. I don't know. So what question was that? And a child with asthma and inhalation of steroid drugs with Cushing's. Okay, I'm not sure like the question as well as the options. We have been seeing the group, but I don't know. So I couldn't get any options like this. Low dose DEXA, then high dose DEXA. Give steroids and then check cortisol. Patient on SLE, taking steroid develops Cushing's. Okay, all right. So what's the actual question on that? Patient with SLE, taking steroids, develops Cushingoid features. What's the question? Okay, adult on steroids, test to do Cushing. Check cortisol and then ACTH stimulation. I have to get the exact question right because this looks like a little complicated. Next step to evaluate. Okay, it's okay. So we'll discuss that later on. So I'm not very sure about that question. I've asked so many times, but nobody replied to that. I'll ask in the group again. Map kinase related, not able to recall completely. I'll just make a note of it. Okay, all right. So there was something with regards to NSIP, I think. They have given HRCT and the X-ray picture. So probably NSIP. They asked which is correct or which is incorrect. That itself is like confused among most of the students because most of the students are discussing most of the physiology and pharmacology questions in the group, but they were not able to recall most of the medicine questions. I understand because most of the medicine questions are close options and it's not that easy to deal with because it's clinical questions also. So I don't know. So there was a question on NSIP. That's what they said. They asked which is correct or which is incorrect. I don't know. You have to say. Absolutely. So it was related to rheumatoid arthritis. They say there was an option of fibrosis and honeycombing on one of the questions, one of the options. See, I'm not asking the fact that UAP has honeycombing here. I'm just asking the fact that what was the exact question? I don't know, unless until you say that it's really difficult. Okay, leave it. So botonier deformity was another question. I think Apusa said that. There was an image that showed hyperextension of the DIP and hyperflexion of the PIP joint. So that's basically the botonier deformity. All right. Yeah, unless until you tell the exact options and the exact image given, it's really difficult to find it. First of all, students are quite confused between whether it's correct or incorrect. I don't know. So let us go on to the easy ones. I think they have given something about invasive pulmonary aspergillosis. Invasive pulmonary aspergillosis. The important risk factor is going to be neutropenia, febrile neutropenia. So this is the maximum risk. This has the maximum risk. This is the most important risk factor. All right. That's one. And apart from that, there was a question on Tigaro classification, easy one. Chronic pancreatitis. We have discussed that so many times in our GTs as well. And they asked about the question on most common site for aneurysm, like the berry aneurysm in the circle of Willis. It is basically the anterior cerebral artery. So to be exact, it's going to be at the communication of the anterior cerebral artery with the anterior communicating artery. Okay. Okay, leave the Cushing question. We have to discuss that one more time. So do you think in Cushing syndrome, you're going to see hypernatremia? Not really. Sorry, in Conn syndrome. No, not really. So why Devant is persistently telling that in Conn syndrome it was wrong, Conn syndrome it was wrong. So you don't see hypernatremia in Conn syndrome, no? Sodium absorption is increased, but you don't see practically hypernatremia because of various reasons that we have discussed in the classes. You see hypertension, you see alkalosis, you see hypokalemia, typical features, not hypernatremia. So that's not a common feature of Conns. CD4 count cannot be the answer because the highest risk is febrile neutropenia. We have discussed that so many times in our classes. I don't think there should be any confusion in that. So in HIV patients, even with the CD4 of less than 50, we don't see invasive pulmonary aspergillosis more commonly. It's very commonly seen in patients who are on chemotherapy and having neutropenia, or probably patients who had a kidney transplantation or lung transplantation, especially lung transplantation. Post-transplant, it's very common. Or post-hematopoietic stem cell transplant, it's very common. But I don't think it's going to be common in HIV patients because of, again, various reasons. So cardiomyopathy with banana-shaped ventricle. Okay, you got an HOCM image. All right. So I'm not sure about that. So nobody told about that. Okay. So let me discuss. And there was a question on congenital heart disease, no? So that was actually a PDA. That is persistent ductus arteriosus, where the patient had a murmur beneath the left clavicle, under the left clavicle, that's the Gibson's area, with a bounding pulse. With a bounding pulse. Right? Okay, there was a question on Sjogren syndrome also. They asked about the next step. That's what I heard. So patients had Zika features like dry mouth, dry eyes. So they asked about the next step. Next step is serology, right? So you have to do serology, practically speaking. Schimmer test is fine, but honestly speaking, you have to confirm whether it's a primary Sjogren or secondary Sjogren. So if it's a primary Sjogren, you're going to have anti-ROLA positive. If it's secondary Sjogren, you can have other antibodies positive like your rheumatoid factor or something like that. So serology will be the next ideal test to find out what's going on. Scintigraphy. Okay, fine. So who's going to do scintigraphy? Or who's going to do Schirmer straight away if you're thinking about Sjogren syndrome, first of all? You have to find out the serology, no? So serology data is the most important. Ideally, that's going to be the next important step. So answer is Schirmer plus antibody. So if that is the case, then it's very good. So that's going to be the right answer. But I thought it's going to be between Schirmer versus serology. So if it's both, then 100% yes, that's going to be the right answer. So why you want to do, I mean, practically speaking, you want to really do scintigraphy in a Sjogren syndrome case? Who does that? Honestly, in practice, pick up someone who does that. So patient had a continuous murmur. Then the answer is even more simple. It's going to be a PD. Easy one. Okay, antibody test plus shimmer. Okay, perfect. So then that must be the perfect choice. Right answer. Great. Thank you. Thank you for correcting. So was there a question on type 1 RTA? Was there a question on type 1 RTA? Okay, so there was a question on iris, I guess. It's a TB iris. Patient who took ATT and ART together. Yeah, I got a question like that. Yeah, so HIV patient with TB, how will you manage him? You're going to start ART 2 weeks after ATT. Yeah. So HIV plus TB together in a ART naive patient, you're going to start ART 2 weeks later. Post ATT, yeah. So there was a question on type 2 respiratory failure. I'm not sure what is that question. So I couldn't get any question like that. So what was the question about type 2 respiratory failure? Yeah, there was a question on hepatitis B as well. There are 2 questions, I guess. So one question with regards to HBV serology. And second question was with regards to the prophylaxis, the PEP, post-exposure prophylaxis. Peripheral neuropathy with TB drugs was also a question, okay? ADT question had increased dose of dolutegravir. No, I'm not sure about that. So you have to tell whether it's a single question or a different question. So pre-exposure of hepatitis B. No, there is nothing called pre-exposure of hepatitis B, which means the only thing that we can do is as a pre-exposure prophylaxis vaccination, nothing more than that. There's no drug that can be given. Serology of ABC, I don't know. So there's a question on HBV serology, I believe. So I don't know what that question is. All right. Yeah, management of type 2 respiratory failure in COPD. I think this was a question. Are you talking about a question of acute exacerbation of COPD? I'm talking about this question. And they've asked about the PrEP of HIV. If it's PrEP of HIV, currently we use dual therapy with dolutegravir. Dual treatment with dolutegravir plus tenofovir. Is that the question? There was a PrEP, so pre-exposure prophylaxis for HIV. So yes, we can. So it's actually a double therapy with dolutegravir and tenofovir. So this type 2 respiratory failure question was basically on acute exacerbation of COPD. Healthcare worker, non-responder after complete 6 doses. Okay, so good one. There was another HBV question. HBV, healthcare worker, non-responder. In this case, you have to give 2 doses of hepatitis B immunoglobulin. Okay, so that will be the right answer. 2 doses of hepatitis B immunoglobulin. Do you get it? I think this was the same question that we discussed the GT, right? In fact, the exact same question, if I'm not wrong. Non-responder, non-responder twice. This was the exact same question. I don't know. Okay. So pre-exposure prophylaxis, 6 vaccine already taken. Okay, that is twice, like 2 times into 3 vaccines. Twice the non-responder. You have given 2 times into 3 vaccines. You have to give 2 doses of hepatitis B immunoglobulin. Do you remember that in the 30th GT that you have discussed the exact same question? The GT that people said it was very tough. Zerodin only, zerodin plus tenofovir plus lamivudine. Then it must be tenofovir plus lamivudine. So currently we use dual therapy, which is kind of safe. TLD is not technically for pre-exposure prophylaxis. 2 drugs is enough. So I don't think vaccine is required if already they have completed 2 courses of hepatitis B vaccine. Just a 2 dose of hepatitis B immunoglobulin is enough. Okay, all right. So remaining questions, I think we can discuss later on. Not right now. I think there are so many questions that had a lot of disputed options. Unless until you give me the right options, it's very, very difficult. Okay, thank you so much. I think Ankur sir is waiting to join next. And he's going to continue with Biochem. Thank you so much, guys. Have a good time. All the best for the results. See you.
Dr. Srinivas sir will join.
Okay. Dr. Srinivas is joining. Okay,
Thank you so much, Dilip sir. Yes, sir.
no problem. Thank you so much. Thank you so much for waiting. Thank you.
Thank you, sir. So am I audible? My PPT, I will just share 1 second. So I hope my screen is visible. Please confirm, Shubhamji.
Yes, sir.
Yes, sir.
Thank you so much. Thank you. So, dear students, I just don't want to take your time. So, I will just tell you what are the answers. I think dermatology overall is very easy in this exam. Only 1 or 2, maybe some students might have felt it difficult because they were not straightforward previous year questions. But otherwise, rest of the other questions are all like standard previous year questions only. So I am also checking out the chart. You can put whatever you are having your queries. So this was a match the following type of question. As you can see here, flaxen, it is a pediatrics and dermatology question. So yes, it is kwashiorkor in which you are going to see the flaxen. Auspitz-sign, we have discussed this n number of times. It is seen in psoriasis vulgaris. Carpetaxin, it is discoid lupus erythematosus. Darrier sign, it is seen in cutaneous mastocytosis, which is also called as urticaria pigmentosa. Okay, so I hope these were the options. If anything is different in the chat section, please you can type it down. I am watching the live also on YouTube, so I will get to know if there is any queries, right? So what will be the answer here? CADB, so it will be option A. So if you are having any queries, you can post it in the comment section. Right. Thank you so much. Thank you so much. Sure. Okay, Auspitz-sign with psoriasis was not there. Psoriasis and Auspitz-sign was not in the option together. So can you please confirm what was there in the option, like what was asked? Is there a mismatch in the only Auspitz-sign and psoriasis options? Then maybe they have to give a bonus if at all it is. No, sir, option different. Okay, option are not matched correctly. So if the mistake is on the INI side, they are going to give a bonus. If at all no option is perfectly matching. Okay, so we'll go to the next. If there is any bigger concern, error in the answer. Okay, thank you so much, Vaibhav Jain. I can understand. So in that case, everyone has to get a bonus. There is no other way, right? So this is the next question: syndromic approach, which is not included in the men. So this is basically, we can say, common sense question as from the STD. So inguinal swelling, it is a bubo. We are going to use it in the men. Urethritis, obviously, we are going to use it for gonococcal and non-gonococcal urethritis. Anorectal discharge, it is basically male sex, male MSM. So it is used in the men. So obviously the lower abdominal pain, which is taken care of by the yellow colored kit, is not going to have any role in the men. Not only that, even the kit number 2, which is green colored kit, it is also not going to have any role in the men. So these are the 2 points which are important for you to remember now. Right. So this is also very frequently repeated question, right? So a man coming with recurrent well-defined red patches which were occurring at the same site on 3 different occasions. Lesions fades after few days and they leave hyperpigmentation. So this type of image was given. So is this the same question and this is the same image? Many students told me that this was what was asked in the exam. So if it was any different, you can put in the comment section. If this was the question, this was the image, you should always think of the drug eruption which is fixed at the same site and it is recurrent in nature at the same site due to the fixed drug. So it is a fixed drug, or in the options fixed drug eruption was not mentioned, so you can put drug induced eruption, okay. So I hope there is no any confusion. These were discussed n number of times in our classes, right? 42-year-old farmer. So this is also very much repeated question, and in fact related to this subcutaneous fungal infections, we are having 2 questions in this particular exam. So it is very, very important. So farmer multiple sinuses, and it was mentioned that black colored granules. We have also discussed this in the previous year days, 7th November marathon also. Dependent upon the color of the granules, we can differentiate mystoma into eumystoma and actinomystoma. So why is this mystoma? First of all, because in mystoma we are going to have a triad of granules, sinuses and the swelling. You can see swelling is there in the picture. It is mentioned sinuses, and also you can see there are granules which is given in the question, which are black colored granules. So it is mystoma, and it is mentioned as black colored granules. So black colored granules is seen in eumystoma. Eumystoma is due to the fungus, and in the options, as you can see here, it is Madurella mycetomatis, which is going to be the fungus which is going to produce this eumystoma. Rest all the others are associated with actinomystoma. Okay, right. If genital discharge, okay, some students are giving something in the genital discharge was the other option. Okay, genital discharge, if it is mentioned, then also it is pointing towards the vaginal genital discharge. Was it mentioned? Or ano genital discharge, was it mentioned like that, or is it mentioned as genital discharge? Okay, I am listening. Anorectal not an option. Okay, I have seen that. Genital discharge was mentioned. Is that so, dear students? Yes, please confirm. Acha, only genital was given in this particular question. Students are telling that only genital was what is mentioned. Okay, but even then, if it is coming from genital, it could be a ulcer which is present over the genitalia, which could be present in the men. But lower abdominal pain, it is associated with the pelvic inflammatory disease. So it is obviously a disease which is seen in the woman. It cannot be associated with in the men. So that would be a better answer if you have to mark one of them. Okay, I hope it is clear. So I have noted this. Yes, anorectal discharge was not mentioned. Okay, it is only genital discharge which was mentioned. Genital discharge. Right, any other question? Okay, acha, urethral discharge. 2 is genital discharge. What is that? Dr. K INI-CET. Options are lower abdominal pain, genital discharge, urethral discharge. Okay. Point noted, but still if the lower abdominal pain is mentioned, that is not going to be managed under the syndromic approach for in the males. Okay, I hope it is clear. Any other queries? Right, okay, Ansari is telling in this particular question. So what were the options? Were these the options which were given, or is there any difference in the options? Okay, Madure is what is given, is what is one student is telling. Is that so? So instead of this actinomyces israeli, I think Madure is given. That's what is Ansari is telling, Dr. Ansari. Am I right? So other students, you can just confirm. Yes, please, dear students, just confirm if that is the case, so that I will just make a change in the options. Thank you so much. So it was mentioned as actinomadura. Thank you so much. But still, it is going to be the answer as Madurella mastromatis, or what is the option C is given as Madurella mastromatis, or anything else was given? Okay. Okay. Thank you so much. I think it is the same thing which is given. So answer is going to be still the same thing, right? Okay. This is a next question which students had like in the question they were having many doubts. So please tell me what was there and what was not there. Okay. So histopathology or biopsy image was given, hand-drawn image was given like this, something this students were telling. So there was mention of hyperkeratosis and scaly lesion involves stratum corneum. And in the question, it was mentioned that the lesion represents verrucae. Okay, and there is some virus which infects the keratinized squamous epithelium, and they were asking a statement which is true. So, is this the question which was asked, dear students? Yes. If you have anything else to add or change, please in the comment section you can ask. You can put that. So it was the image which was showing the virus which is being thrown out of the skin from the stratum corneum. So if this is the case, okay, then you have to think of the human papilloma virus. Then related to HPV, what is the true statement you need to identify? So option A, no vaccine available, vaccine is available. So this is wrong. It is oncogenic virus. Yes, this statement is true. And it is non-enveloped DNA virus. So this is a wrong statement. It is a DNA virus, right? This is a wrong. So answer here is going to be, it's an oncogenic virus. Okay. So in this question, if you have any doubts, you can put in your queries in the comments. And this question, I can say it's like looking like a one liner, but there is a concept behind this. Actually, usually the malignancies are common over the sun exposed areas. So you may think that, okay, this is a melanoma, so we can mark it as a phase. But remember, in the Indian population or in the dark skinned individual, it was observed that the most common site is going to be the acral areas, acral melanoma, that is over the palms and soles. It is, we are going to see commonly the melanoma in the patients who are dark. Okay, right. And this is actually a previous year question which was asked. So again, they have repeated, we can say it was INI question itself. So elderly post-menopausal woman, was this mentioned in the question today? Please put your feedback in the comments. Okay, 65-year-old post-menopausal woman, intense itching and soreness in the vulvar region. Examination revealed there is white atrophic parchment-like skin. So these words were described in the question is what students told me, right? White atrophic parchment-like lesion was seen over the vulva. Epidermal thinning and loss of rete ridges and hyalinized collagen. These were all points which were mentioned is what students told me. So what is the most likely diagnosis? So remember, dear students, whenever you get in a post-menopausal woman, a lesion which is intensely itchy in the vulvar area associated with atrophy. then you should think of one condition which is called as lichen sclerosis. The full name, the complete name is actually lichen sclerosis yet atrophicus. It is lichen sclerosis yet atrophicus, which is going to present with intense itching, and there is going to be very, very thin skin. And that is the reason why we are going to see this epidermal thinning histopathologically, right? And these patients should be kept under close monitoring, because there is a possibility that they can go into the lesion can develop malignancy, SCC. Okay. Right. So these were the questions which were asked. If you are having any doubts, okay, or anything if you feel is different which was asked, please put in the comments. I am watching the comments, and also you can tag me on Cerebellum Academy official Telegram group and ask your queries. Okay, thank you so much. I hope this marathon and the missions were helpful in answering all the dermatology questions, and I hope you felt the dermatology was easy in this exam. Thank you so much. Just relax, and again we are going to meet in the in-app version with detailed explanation, okay, with the changes which you have told, right? Thank you so much.
Thank you so much, Srinivas sir. I think Janvi ma'am is going to be the next one, taking care of the anesthesia questions.
Thank you
Over to
so
Janvi
much.
ma'am.
Thank you so much.
Sir.
Thank you so much, Per sir. I have only one question to be discussed. So, which of these is not an advantage of ketamine? There are lots of versions of these questions. If this is the exact question, then A, used as an induction agent, yes. B, helps in the action of opioids, yes. So, ketamine has an analgesic effect. So, it also helps whenever you want to use it along with opioids to reduce the use of opioids as an analgesia. Okay. Option C, causes dissociative anesthesia. Now, this is not an advantage of ketamine. Dissociative anesthesia means the patient goes into a trance-like state. He feels disconnected from his body. Body and soul feel different. So this cannot be an advantage. In fact, it scares people to be in that state. So I would mark that as the answer. And option C, reduces tolerance to opioids. So a lot of people are saying this is the answer, but that's not correct. Why? Because in chronic pain, when people have been taking opioids for a long period of time, at that time, if you want to reduce the dosage of opioids or the use of opioids, what we do is we give them sub-anesthetic doses of ketamine. Now, what happens is that this opioid tolerance causes increase in the number of NMDA receptors. Okay. And as we know, ketamine is a blocker of NMDA receptors. So this upregulation of NMDA receptors can be taken care of by giving something which antagonizes them, that is ketamine. So in chronic pain, we do use ketamine to reduce the tolerance of opioids. So the answer over here is C, causes dissociative anesthesia. There was a block, greater palatine nerve block, but that is not given by anesthetist. It is given by ENT people, and Dr. Praneeth has discussed that. It is used for palatal surgeries under local anesthesia. So that has already been covered in ENT. So this was the only question from anesthesia. Thank you so much.
Thank you so much, ma'am, for that wonderful discussion. I'll be just taking a few minutes of your time having a discussion, and I just wish to reassure people that even though some of you felt as if somebody had given ketamine to you in the exam as well, but after having the discussion on the recalls, perhaps you are going to be feeling a bit better. I'll just talk about certain questions. There were around 15 plus questions which were given in the exam. The first question was an easy one, which I got. That was pertaining to the diagnosis of nephrotic syndrome. If you can just let me know what exactly was given in the history of the question. But what I could gather was that this was one question pertaining to the diagnosis of nephrotic syndrome, and the options given were, patients were having massive proteinuria more than 3.5 grams per day. That was the first option. The second made a mention of hyperlipidemia. Some people said hypercholesterolemia was what was given. The third said hypoproteinemia, and the fourth said hypertension. So it was a combination type of question. 1 and 2 are correct, 1, 2, 3 are correct, 1, 2, 3, 4 are correct, something of that sort. Of course, you are aware of the fact that if I'm talking about nephrotic syndrome, patients are going to be having the presence of massive proteinuria. They would be having the presence of hypoalbuminemia. They would be having the presence of hypercholesterolemia as well. But hypertension is not a classical feature with respect to nephrotic syndrome. So I presume that is what most of you had an idea. The second one may have been discussed with you, maybe in radiology or with respect to medicine questions as well. Kindly just let me know in case there is something that you wish to add. This was a question which talked about a 28 or a 38-year-old male who was having the presence of jerky involuntary movements. And I think the question did make a mention of loss of memory as well as the presence of coriform movements. And the MRI showed you the presence of the boxcar ventricles, and you just were supposed to make a diagnosis. हाइपरटेंशन नहीं था, हाई क्रिएटिनिन वैल्यू था, तो हाई क्रिएटिनिन वैल्यू नहीं होगा यार उसके अंदर। ये तो हमें, वी डू हैव एन आइडिया, high creatinine value is what is not going to be seen in context of nephrotic syndrome. That's what you just need to have an idea.
Sorry to interrupt, Dr.
Right?
Swartz.
Sorry, sir. Sir.
Are you sharing your screen? Because your screen, I think, is not
No,
visible.
I'm not sharing, sir. I'm not sharing. We are going to coming up with a recall, sir.
Okay.
Pretty sure. Thank you. Right? So, PPT में यार वो राइटिंग इतनी गंदी है भगवान के जैसे कि आप उसे क्या ही देखोगे। मतलब आई वुड जस्ट रिक्वेस्ट यू टू बेटर हैव अ लुक एट द क्वेश्चंस इन जस्ट कपल ऑफ डेज. वी आर गोइंग टू बी कमिंग आउट विद द आंसर्स. So Huntington's chorea was what was given in the exam question. I think we had a discussion on this one with regards to the CAG repeats and with respect to the marathon and the mission classes as well. Then we had a question which was talking about a teenager patient who was having the classical history. He was having the presence of fever. He was having the presence of bone pain. He was having the presence of increased value of ESR. He was having leukocytosis. And perhaps a question which was making a mention of the radiological appearance of a moth-eaten appearance of the right humerus bone. So when we are talking about an osteomyelitis-like feature in case of a patient, we are going to be having a clinical diagnosis of something like Ewing sarcoma. Now, what I could gather was, in the short time I could get, that they asked you about how to make a diagnosis of this kind of a patient. So ideally speaking, if I'm talking about Ewing sarcoma, the best way of making a diagnosis would be obviously to carry out a biopsy. And the biopsy shows you what we have talked about earlier. The patients are going to be having the presence of SRBC or the small round blue tumor cells. Right. We then had a question pertaining to a patient having long-standing history of smoking. And then this patient was having the presence of features suggestive of drooping of the eyelids, that was ptosis. There was presence of constriction of pupil. There was presence of a neuralgic pain coming from the shoulder as well. And there was a mass which was seen in the upper lobe on the chest X-ray. So all pretty much suggestive of the development of the Horner syndrome, and the patient was having the presence of the Pankos tumor. Again, diagnosis is being confirmed on the basis of the biopsy, and usually you are going to be taking the biopsy from the radiologically assisted biopsy. That would be a CT assisted biopsy. That is perhaps what was given as a question. What just now sir discussed about the fact the commonest site for the development of melanoma in the Indian population. If you had ever watched the videos that we had with respect to the updates of the Robbins 10th edition, we already had a discussion that in the Indian population, unlike the Western population, two important facts. It is the basal cell carcinoma, which is much more common in comparison to the squamous cell carcinoma. That's fact number one. The second fact is that in case of patients who are going to be having a melanoma, it is classically seen in the non-sun exposed areas. Right. So the classical site is not the face, but it is going to be the palms and soles in context of melanoma. The next question that made a mention of in the exam was pertaining to what perhaps Gaurav sir is also talking about and teaching in detail with you. That's pertaining to retinoblastoma. But the question was not about retinoblastoma. It was a question on the RB gene. So the question made a mention of a child who was having the presence of an eye tumor, and microscopic examination showed you rosette formation. And the question was, which of the following statement is true pertaining to the gene involved? So I'm just going to be reading out the statements. Is this tumor always going to be unilateral? The answer is no. Sir has already told you that majority of the people are going to be having a unilateral retinoblastoma, but of course, in familial cases, it can be bilateral. The second is gene is also called as guardian of the genome. Absolutely not. This gene is given the name of governor of cell replication. Guardian of genome is a term that you are using for the P53 gene, right? The third one statement was it is inactive when it is hypophosphorylated. Again, incorrect. If you have watched the main videos in the neoplasia section, guys, this gene is a tumor suppressor gene. तो वो ट्यूमर सप्रेसर जीन कब काम करेगा? When it is hypophosphorylated. It becomes inactive when only it is going to be phosphorylated. Right? So ये तीनों चीजें गलत थी. The fourth option was that there is cancer oncogenesis pertaining to this gene is associated with loss of function mutation. Absolutely true. Whenever we are talking about a tumor suppressor gene, it's a loss of function mutation which is going to cause a cancer. Finally, making a mention of associated with increased risk of development of osteosarcoma, again something which is known to you, that RB gene is associated with not only the retinoblastoma but also associated with higher risk of development of osteosarcoma. So the first three options were incorrect. The last two options were correct. That's what I just wanted to talk about. Then we had a classical question in which the patient was having the presence of an anemia and he was having the presence of an increased RBC count. Menzer index value of 11 was given to you. They just asked you what is the next best investigation to confirm. So when I'm having a Menzer index value of 13, that means 11, that means less than 13, I would be suspecting something like thalassemia. So the options given in the exam were ferritin. Just do correct me if some other option was given. The second one which was given in the exam was the presence of bone marrow biopsy. The third one is hemoglobin electrophoresis, and the fourth one is serum transferrin. If I'm suspecting thalassemia, out of the given options, this one is going to be associated with the presence of the hemoglobin electrophoresis. Yeah, Dr. Hu says 4 plus proteinuria, steroid resistant, but no hematuria, no other proteinuria. No, you itself contraindicate your statement, friend. You say it is 4 plus proteinuria, then you say no other proteinuria. What is the meaning of no other proteinuria? Biopsy shows presence of sclerosis and mesangial. No, can somebody just help in the recall of this particular thing? I think you could just make a comment or just tag me in the Cerebellum Academy channel as to what was the exact option that you wish to talk about over here, my friend. I think that would make a thing bit more easier. भाई आप क्वेश्चन तो अपना ठीक से बता दो, मैं आंसर तो कर ही दूंगा तभी. So the next one talked about the biopsy finding in the patient who was suffering from obstructive jaundice and he was having the presence of the onion skin fibrosis. So we have talked about the story so many times earlier. It's a feature that we see in patients suffering from primary sclerosing cholangitis. We then had a question which was talking about the causes of anemia. I think multiple options, correct option. The patient had anemia and he had a MCV value of 76. Which of the following can be the causes? The options were lead poisoning. The second question, the exam was thalassemia. The third option was iron deficiency anemia. The fourth was B12 deficiency. So of course, B12 deficiency is going to be a cause of megaloblastic anemia. The rest three are causes of microcytic anemia. That's something that you can be picking up with the help of MCV value of 76, right? So if there is any change, just do let me know over here. Sclerosis था biopsy के अंदर. I think we are talking about two different questions, Doc. One is criteria for making a diagnosis of nephrotic syndrome. And the second question, I think, is a pediatrics question, which is making a mention of a child having the presence of massive proteinuria and showing you a biopsy finding of sclerosis and the involvement of the mesangium. ठीक है? तो then we had a question which was talking about the staining. I think that was an easy question because उसके options exam के अंदर pearl stain useful for detection of iron and the color is red. So we talked about the fact pearl stain means Prussian blue color आएगा. So that was incorrect. When I'm talking about alizarin red, it is giving a calcium and useful for as a black stain. No, alizarin red obviously gives you a red stain. That's what is known to you. The third one talked about the presence of Van Giesen stain showing elastin and blue. Van Giesen is going to stain elastin black in color. We have talked about it earlier. You know, VVG वाला stain हमने discuss किया था. And then we also talked about GIMSA staining the mast cells purple color. So yes, we talk about the fact that mast cells are going to be showing you the presence of a metachromatic staining. And therefore, toluidine blue is one stain. The second one can be the GIMSA stain, which can be useful for picking up mast cells. Right? So that is what we just need to remember. We then got a question regarding to the classical often asked topic of Peutz-Jeghers syndrome, and you had to talk about what statements were true and what statements were false. I read out the statements. Peutz-Jeghers syndrome is an example of an autosomal recessive disorder. False statement, it is autosomal dominant. The second one talks about Arbo's rising smooth muscles on the histological examination. Absolutely true. The third talk about associated with extra-intestinal manifestations apart from polyps in the intestine. Again, true. Patients have pigmentation. They are at high risk for development of cancers. The next question was the patient is having the presence of numerous intestinal hematomatous polyps. Absolutely true. So we understand the fact that it is not an example of an autosomal recessive disorder. It's an example of an autosomal dominant disorder. स्टेन क्वेश्चन में मल्टीपल ऑप्शन थे, वही मैं बता रहा हूँ ना, मैंने 4 ऑप्शंस दिए थे और सबके सामने उसके फीचर्स मेंशन थे. व्हाट इज द सब्सटेंस बीइंग स्टेन्ड एंड व्हाट इज द कलर बीइंग ऑब्टेन्ड. दैट्स व्हाट वी मेड अ मेंशन ऑफ. Then we got a question on the, talking about picking up the major and the minor criteria pertaining to the revised Jones criteria. So of course, the options given in the exam were carditis, fever, erythema marginatum, short PR interval, and Sydenham scoria. So Sydenham scoria obviously is a major criteria. Carditis, of course, is a major criteria. If I'm talking about erythema marginatum, that's a major criteria. The fever and the short PR interval are example of minor criteria. Again, something which was not too difficult, I believe. एक ऑप्शन था ST के 11 मुकेश, थैंक यू इफ यू कैन से. तो मतलब ST के 11 था, तो फिर तो ये सिंगल ऑप्शन करेक्ट नहीं हुआ, फिर तो ये मल्टीपल ऑप्शंस वाला क्वेश्चन हो गया. कैन यू जस्ट कंफर्म दैट सेम फॉर थिंग फॉर मी. रेटिनल पिगमेंट एपिथेलियल हाइपरट्रोफी नहीं होती भाई इसके अंदर. ठीक है. Then we got a question in the exam pertaining to which of the following is a correct statement regarding rheumatic heart disease. So options given in the exam were associated with aortic valve rupture. No, it's a mitral valve which is affected most commonly. Second option talked about patients are having only myocarditis. No, it is not true. Third, making a mention of the group B streptococci are involved. Again, not true. You are aware it is a beta hemolytic streptococcus. Yes, that is what you need to be familiar with. Okay, multiple options. ठीक है जी. Thank you. And then the question made a mention of Ashow's body are present. So ये तो हमने multiple times discuss किया, वो classical image Wikipedia से लेके जो आपको देते हैं, that patients are going to be having the presence of अच्छा erythema nodosum था उसमें mention. Okay. So marginatum नहीं था, तो nodosum तो कहाँ से होगा यार? Nodosum is not going to be a criteria. So major and minor मतलब आपको major and minor differentiate नहीं करने थे कि how many major, how many minor. You just have to talk of which of is an example of both major and minor. So out of 5, 4 are included. That means Sydenham chorea is there, carditis is there, short PR interval is there, and of course patients are going to be having fever. फिर तो erythema nodosum is not going to be seen as a feature ना. Then we got a question pertaining to the markers of mantle cell lymphoma. So mantle cell lymphoma, we talked about two important markers that we always make a mention of. One, of course, is CD523 negative. The second one that we talk about over here is the fact patients are going to be having the presence of cyclin D1 positivity, and we are having the presence of the SOX11. The other options were CD10. CD10 can be is something that is going to be seen positively in these patients. इसका example of a B cell tumor. ठीक है. CD200 is not a marker for mantle cell lymphoma. It's a marker for CLL. So of course you know the fact that double century CLL के साथ में होती है. That's what you need to remember. CD23 is also a marker that is seen with CLL. In fact, presence of CD23 and CD200 is how you classically differentiate between mantle cell lymphoma and the presence of the CLL. So CLL patients will be having CD23 positivity as well as CD200 positivity. But if I'm talking about SOX11 and CD10, they are positive in context of mantle cell lymphoma. Then we got a question which Dilip sir also discussed with you. Patient was a basketball player. He had a sudden cardiac death. He was playing, and then it was a classical image, gross image of the heart showing you the presence of the banana-like ventricular cavity. So of course it's a case of the hypertrophic obstructive cardiomyopathy. ठीक. Then we got a question on Gaucher's disease. If you can just let me know. I think Ankur sir may have also be talking about the same. It is having the presence of that crumpled tissue paper appearance. You are going to be having the presence of the deficiency of the enzyme glucocerebrosidase. And if you can just let me know more options, I can just add to it over here. True statements about Gaucher's disease. Maybe I can take the question from Ankur sir as well without wasting too much of our mutual time. In case you can add on to something regarding this question, please do so now. ठीक है जी. Right. Then talking about what Dilip sir also made a mention of, that was pertaining to a question on which the patient was having the presence of dry eyes and dry mouth, dry buccal mucosa and bilateral salivary gland enlargement. So this was associated with what is the next best finding. So we are suspecting a patient to be having Sjogren's syndrome, and subsequent to Sjogren's syndrome, you are going to be doing what? You are going to be determining the presence of the antibodies in these patients with the help of serology, right? And then what can be done for these patients is going to be, ideally the treatment should be done with the help of biopsy. So biopsy question was an older question, but I think this time around the question in the exam was next best step. So you detect the presence of the antibodies, the anti-Rho and the anti-La antibodies. That is what we need to remember. Acha, foamy macrophages and sphingomyelinase. Okay. Just give me a minute, sir. Okay, got it. Thank you. ठीक है, major minor में से कोई भी pick up करना था. Then we got a question in the exam which was discussed with you with respect to the Nobel Prize in 2025 pertaining to physiology medicine. ये तो मैंने discuss किया था यार, T regulatory cells के ऊपर मिला था, which was the concept of the peripheral tolerance, right? So I hope none of you got that question correct. At least वो तो आपको खुशी मिल गई होगी एक. And finally एक चीज बता दो, question जिसमें I am not too sure what was given over here. People said some epigenetic modification question was asked in the exam. अच्छा, शर्मल्स टेस्ट विद एंटीबॉडी था. शर्मल्स टेस्ट तो आपको गौरव सर ने पढ़ाई रखा है फुल तरीके से, इसमें तो कोई डाउट ही नहीं है. आई थिंक सर इज गोइंग टू बी टॉकिंग अबाउट इट अगेन, है ना. लास्ट चीज बता दो मेरे को, जस्ट ट्राई टू गिव मी द ऑप्शंस फॉर सम एपिजेनेटिक मॉडिफिकेशन. नाउ वाज इट द क्वेश्चन व्हिच टिपिकली टॉक्स अबाउट द हिस्टोन डीएसिटाइलेशन एंड डीएनए मिथाइलेशन, समथिंग ऑफ दैट सॉर्ट, or did they specifically make a mention of something else as an option? Epigenetic modification तो ऐसे ही करते हैं ना आप. Non-inheritable changes which are going to be responsible for sometimes development of features which can be seen. DNA, okay, methylation भी था, histone deacetylation भी था. And what was the question about? Was the question about the mechanism of epigenetics or was it about something else? Now, some people came up with very strange options. They talk about some, HK9 or something of that sort as an option. वो confirm कर दीजिए please if there was something of that sort. So we made a mention of epigenetics in context of neoplasia primarily, wherein we are going to be looking at the differential action. Histone deacetylase inhibition is what is being used for the treatment of cancers, doc. If you have heard of a tumor called as cutaneous T-cell lymphoma, we are having a drug that is given the name of romidepsin, and we have a drug given the name of vorinostat. ये previous INI questions हैं. So, Dr. Gagan, that is what is useful for treatment of cancers. Inhibition of histone deacetylation is given for treatment. If you can just let me know, I mean, please do tag me in the chat box in the Cerebellum Academy channel as well, or else you can just make a mention of it over here. So those were the 18 or 19 questions that I just wanted you to have an idea with me. H3K, H27. Okay, I'll just look it up in case there is something which is available at my end with regards to the information that you have just now shared. So all in all, so far as the subject of pathology was concerned, I would say it was not a very difficult paper, but of course, as I understand, During the exam, it's a stressful situation, so we cannot expect everybody to maintain their cool. Easier said than done. Nonetheless, the good thing is exam is over, right? So just do take good care of your physical and mental health, recharge yourself, and get ready for the NEET PG exam. Let's get ready for the mission classes. And over to Gaurav sir. Thank you so much, sir, for waiting patiently. Thank you.
Thank you very much, Professor. Thank you very much. Thanks a lot. And yes, retinoblastoma was a question which was there in my radar also, but I was not getting the correct options. And thankfully, you have covered that. So let me just quickly share my screen. And this is the first draft that I have got. So the first question that is there was a 60-year-old female who comes with a sudden onset severe pain, blurred vision, headache, nausea, vomiting. On examination, has a hazy cornea, a shallow anterior chamber, and a fixed dilated pupil and a stony hard eye. What is the diagnosis? This is a very classical diagnosis of what? Of primary angle closure glaucoma, acute angle closure glaucoma, acute angle closure glaucoma attack. Okay, that was a very, very straightforward question. Was that okay? Easily catchable? No doubts in this. Okay, phacomorphic glaucoma is seen after hypermature cataract, so that was not there. Okay, and there is a sudden onset. So this is an acute. It was a very, very simple question. IOP 60 also given. Okay, thank you. IOP of 60 millimeters of mercury, that again goes in favor of ankylosing glaucoma. है Very, very simple question. Thank you, Dr. Mukesh, Dr. Agan. Vision problem, headache, yes. So headache is there. Vision problem, blurred vision, all are there. Okay, colored halos. Colored halos was also mentioned. Okay, colored halos was also mentioned. I'll note this down also. That is also correct. Thank you, Dr. Tanushree. Secondary angle closure भी था option. Secondary angle closure. Okay. तो इसमें से फिर कौन सा नहीं था? Which was not there? Secondary angle closure was there. Then which was not correct? Steamy cornea was mentioned. Is it uveitis associated? Uveitis plus secondary glaucoma. But uveitis plus secondary glaucoma. Okay. But for uveitis, you have to have cells. Okay. There has to be cells. And the pupil is going to be small. Okay. It is not going to be a dilated pupil. Okay. In uveitis, classically because the iris is irritated, so the pupil becomes small. A नहीं था. Okay, ठीक है. A नहीं था. हटा दिया A. Okay. नहीं, Krukenberg spindle का question is different, बेटा. Krukenberg spindle का question is different. ठीक है. Secondary acute angle closure. One is saying secondary open angle. Okay. Secondary open angle. Secondary open angle क्या होगा? Secondary open angle would be like you have this your pseudo-exfoliation glaucoma, that kind of thing. One option was neovascular glaucoma. Neovascular glaucoma पक्का इसी में था या Krukenberg में था? Krukenberg का एक question अलग है. There is a different question which is there for Krukenberg spindle. Okay, correct. I think you guys are confusing those two questions. Let us move to the second question. Now, this question was a very, very tricky question. Okay, history of chronic rubbing with high myopia with astigmatism present with sudden painless था, painful था. Painful loss of vision in one eye. History of frequent change of glasses earlier. Visual acuity is reduced to perception of light. Slit lamp image was given like this. Okay. Slit lamp image was uveitis plus secondary glaucoma. But अगर uveitis plus secondary glaucoma भी था, तब भी, even if it was uveitis plus secondary glaucoma, so uveitis will present with small pupil and there has to be history of cells and frequent change of glasses वगैरह वो सब चीज ये नहीं होगा. क्या नाम है? सडन ऑनसेट नहीं होगा. ठीक है, करेक्ट है. तो प्लीज, तो ये क्लियर है. उसमें एक्यूट एंगल क्लोजर ग्लाइकोमा ही था क्वेश्चन नंबर 1 में. नाउ क्वेश्चन नंबर 2. हाँ, तो क्रॉस लिंकिंग ये रहा ना बेटा. दिस इज कॉर्नियल कोलाजन क्रॉस लिंकिंग. दिस इज कॉर्नियल कोलाजन cross linking. Just tell me, was this kind of image which was given with a bubble in the AC? Was this there air bubble or a gas bubble in the AC? Exactly my option. Okay, good. So if this was the correct image, then the answer is this: intracameral C3F8 gas. Intracameral C3F8 gas is the correct option, beta log. This is the management of acute hydrops. Acute hydrops, which is a complication of keratoconus. It's a complication of keratoconus. Okay. I was expecting a question on keratoconus. This I had mentioned in my last sprint class also, last minute question also. I was expecting a question on keratoconus, but this is too much. Please let me say it on the platform that keratoconus ka complication is hydrops. Hydrops ka management is going to be intracameral C3F8. Now, intracameral C3F8 as a management of acute hydrops, even many ophthalmologists will not know about this. I being a cornea surgeon, I know this, but I being a teacher, I know this, but many ophthalmologists will not know this management. So to be expecting this from an undergraduate is too much, but still it has been asked. This was a way top question. It is a PG level question which they've asked. So yes, this was a very, very difficult question. And the answer is intracameral C3F8, which is used for management of acute hydrops of keratoconus. Okay, correct, understood. नहीं बेटा C3R is for C3R में बेटा ये नहीं है. Listen, C3R is for managing the keratoconus from progressing. Okay, and C3R there is not going to be an air bubble. In C3R there is no use of any gas or air bubble. Okay, so please understand this. Correct? ठीक है, तो C3R नहीं है ये. C3R is the management of keratoconus. Okay, but in keratoconus you do not get the visual acuity reduced like this. Okay, this is not going to be there. So this is the diagnosis is acute hydrops and the management is intracameral C3F8. Okay, so next question was this. There is a contact lens user present with severe pain, redness, watery discharge from the eye, acanthamoeba keratitis suspected. This line was there. Was this line there? Was this line there or not there? Acanthamoeba keratitis suspected. Was this line there? Please mention. Okay, which of the following stains is most useful? We know for acanthamoeba, the stain that is used is calculated white. This we have done in our class. And this is a classical ring shape ulcer, which is a classical for acanthamoeba ulcer. Acha, no, not there. ठीक है, चलो, even if it was not there, so I'll just cut it off because I was having doubt कि acanthamoeba directly mention नहीं करेंगे. ठीक है, but they have given this kind of ring shaped ulcer. Some people are getting confused with this as being pseudomonas. But a pseudomonas ulcer will not be like ring shape ulcer. It will have a hypopion. So it is not pseudomonas. Okay. And very, very important point. Severe pain. Severe pain denotes acanthamoeba. Severe pain, okay, denotes acanthamoeba. Okay. So that is calculable white. Good. Next question, which was there. This crocodile spindle is seen in which of the following conditions? The answer is pigmentary glaucoma. This also I had done in last minute question. It was very, very straightforward. Pigmentary, we have done this as an image-based question also, and it was very straightforward question. Okay. Okay. So these were the 4 questions that were there. Apart from this, there was a question on the retinoblastoma gene, which Dr. Sparsh has already covered. Dr. Sparsh has already covered. Okay. So this is cancer-causing gene due to loss of function is oncogenic. Guardian of genome is P53. Retinoblastoma is not always bilateral. It is mostly unilateral. In very few cases, it is bilateral. Okay. It was very few cases. Correct. So these are the 5 questions which I were able to track. Apart from this, any other question that you guys know? And I sincerely want to thank all of the people who have helped me in getting this recall. Many students have given these answers. So apart from these 5 questions, was there any ophthalmic question? One question that Dr. Sparsh has mentioned is about the Pancoast tumor. Pancoast tumor, where the patient is presenting with ptosis, meiosis, the Horner syndrome. That is also partially an ophthalmic question. Acanthamoeba was not mentioned. Okay. Unilateral given one option. Unilateral given one option. इसमें unilateral भी था. Okay, I don't think unilateral tha because Dr. Sparsh just now made this question clear. I'll catch this question from Dr. Sparsh, sir. Okay. Apart from this, apart from these, or any other question you guys have come across? Am I missing any question? Because there are only 5 questions which are there. Pigment dispersion syndrome हो गया. Pigment dispersion syndrome हो गया. Krukenberg spindle is seen in pigmentary glaucoma, also called as pigment dispersion syndrome. Okay. ठीक है. RB is always unilateral. नहीं, always unilateral भी correct नहीं है. डॉक्टर गगन, always unilateral भी नहीं है. Bilateral नहीं था, unilateral था ऑप्शन में. देखो, always unilateral भी नहीं होता, always bilateral भी नहीं होता. It is both unilateral and bilateral. ठीक है. So it is never exclusively unilateral, never exclusively bilateral. Okay, correct. This Dr. Sparsh has clearly mentioned is due to loss of function. Is genes का role है. So there is more of pathology here. ठीक है. शायद क्वेश्चन में patient had presented with a flexed nerve intercellular rosette. ऐसा कुछ क्वेश्चन था शायद. Okay. Yes. Thank you. Thank you, Dr. Gagan. Thank you for clearing it out. And if no more point from you, then I'll just move on and I'll hand over it to Dr. Praneeth sir, who is just waiting in the queue. Any other question you guys think? Any other question as per you? So as always, only 5 questions came. So Ofthal is maintaining their strike rate, and one was bouncer, which was absolutely a bouncer. Believe me, it is totally a bouncer. The keratoconus, the question that we have given is a bouncer one. Okay. So thank you everyone. Thank you, Dr. Praneeth sir, for waiting, and I hand over it to you, and we'll come out with the final. It was easy. The 4 questions were easy. One question was absolutely bouncer. Everybody would have got it wrong. Everybody. I don't think anybody would have been able to get it right, except for people who had the presence of mind to understand that there is a gas. So they would have marked gas. If somebody kept a presence of mind, okay, if somebody was smart, okay, then by looking at the image, okay, just by looking at this image and seeing that there is a gas bubble, if somebody marked gas, just by this clue, by a simple clue, otherwise by knowledge, I'm very, very sure no undergraduate would have been able to mark this. Okay, correct. So over to you, Dr. Praneeth sir. Thank you very much, please.
Thank you, sir.
Okay, sir. I'll just stop sharing.
Okay. So ENT was, I think it was relatively not so tough, at the same time not so easy. Fine. So quickly moving on to the questions. The first question, noise induced hearing loss. You know mostly the 4 kilohertz area, 4000 hertz area, which is a high frequency area. So high frequency are at basal turn of the cochlea. So the option will be at the basal turn. Yes, you might have, okay, confused with the outer hair cell, but apical turn is concerned with the low frequencies. So this is the only twist they have given, but absolutely, definitely high frequencies are related with the basal turn. Fine. Any doubts here? Any doubts here? No? Okay. So next question is prelingual infant screening, which is not used. See, in prelingual infant screening, subjective test can't be used. Your pure tone audiometry is a subjective test where it requires the responses given by the subject. Whereas in case of BERA otoacoustic emissions, there is no no responses needed to be given by the subject patient, right? Okay. So PTA is a subjective test, so that is not used. Free field audiometry is you give sounds from different sides, okay, from right side, from left side, and you will see whether the child is moving his head towards that side or not. So that is free field audiometry. So that is also objective only. Of course, the child will give responses by turning his head, not by telling that he is able to hear or not, just like an adult, right? Fine. Now, so this cannot be an answer. Now, a patient of glottic carcinoma with a lesion on right and left vocal cord Right chord is fixed. I told you in the classes, if the word fixed is given, you fix your answer to T3. And yes, you might have confused, maybe if you have understood the next line clearly, there was invasion of the inner cortex. They told that it is invading only the inner cortex level, not it has come outside, it has extended beyond. So it should be at the T3. If it had extended beyond to T4A could have been, right? So fixed T3 is the blind thing I told you to remember. The moment you see fixed, you fix your answer to T3. That was what I told. Yes? Right. Now steps of phase are exact options were not recollected, but it goes in this way. I told you in the class. Okay. So this is your right nasopharynx area, right? You have the uncinate process here, and first part of middle turbinate, second part of middle turbinate, third part of middle turbinate, bulla ethmoidalis, anterior ethmoids. You have the maxillary sinus opening here, posterior ethmoids, right? So first step is you will remove the uncinate, right? Uncinate, and then you will widen the maxillary ostium. Then you will go for ethmoidectomy, anterior ethmoidectomy. Then you will remove the ground lamella, second part of the middle turbinate. Then you will enter the posterior ethmoids. You will remove these posterior ethmoidal cells. Then you will go sphenoid, and up you go frontal. Fine. So this is the sequence of how you do for FIS, right? High frequency, yes, T3, yes, right. Okay. Right. So these are the sequence of the steps of FIS. If you remember the anatomy, so these are the steps of FIS. So this was one given. You see the needle is pointed towards this greater palatine nerve area, exactly where the greater palatine enters. This is done for various palatine procedures. Okay. Any molar dental extraction or any palatine tumors removal. If you want to done pyogenic granulomas, or if you want to drain, you will give a palatine block, greater palatine nerve block you will give. Okay. Fine. This is straightforward direct question. The only area you need to identify, in that area, greater palatine nerve will be entering. And internal acoustic. So this is definitely a little bit a difficult question. At your level, it is definitely difficult, but internal auditory canal will be facing towards the posterior cranial fossa side. So how many of you marked it? I don't know. Is this the same thing given? Is this the same CT given? So during recall, a student gave me this one. Is this the same image given? If not, kindly please share the options with me. What are the options given and what is the exact image? But if this was the CT given, the opening which is seen here, it is internal auditory canal. Okay, fine. So now, so these are the questions that you got in ENT. So this was easy. Noise induced hearing loss, high frequency, easy question. Prelingual subjective test, infant cannot give responses, subjective PTA, easy. Fixed vocal cord T3 stage, easy. Steps of FES, okay, a little bit medium difficulty. Greater palatine direct question, and CT is difficult. So one difficult question, three easy questions, right? Any other questions? If still there, kindly do share. So kindly do share, and I'll add it in the final recall video. Fine. So with this, I'll be handing it over to the next person in live. Next faculty, sir.
Good evening, sir.
Good evening. Good evening, sir. Yeah, I'm moving this. Just a second, sir. Yeah. Yes, sir. You can take over.
Okay, sir. Thank you. Very good evening, friends. Yes. So first question is, which enzyme defect will lead to increased 2,3 DPG or BPG? Yes, leading to low glucose in vitro. This point is important. As you know, in RBC, Rappaport-Lewis shunt, we know 1,3-biphosphoglysrate is converted to 3-phosphoglycerate by phosphoglycerate kinase. If phosphoglycerate kinase is not there, definitely this will be diverted towards synthesis of 2,3-DPG. Yes. According to few students, option E was pyruvate kinase. Pyruvate kinase. So answer is B. For the time being, answer is B. If option pyruvate kinase is given, yes, if pyruvate kinase is given, they have given the word, two words, in vitro. First thing, yes, and glucose is low. Yes, if pyruvate kinase is not there, glucose should be high. Okay, dear. So if one to choose between pyruvate kinase and phosphoglycerate kinase, I will go with phosphoglycerate kinase. Any other point? Yes. Now, so second question, very repeat question. Every time they ask steps in PCR in order. Yes, denaturation, two strands are separated, annealing, primer get annealed to DNA, extension or elongation, polymerization of DNA. Yes. Okay. So denaturation, annealing and elongation. This is the answer. Answer is A. Answer is A. Hybridization is a, yes, we use in blotting technique. Yes. Next question. Yes. Next question. Any doubt? 1-year-old child is suspected to have glucose 6-phosphatase. Glucose 6-phosphatase deficiency. Yes. That is bone glucose disease. Glucose 6-phosphatase is deficient. Kidney enlarged, increase lactic acid, uric acid, triglyceride increased, and there is fasting hypoglycemia. Yes, fasting hypoglycemia. You know, whenever liver glycogen storage disease, main feature is fasting as hypoglycemia. So answer is fasting hypoglycemia. Yes, answer is D. Next question. Which of the following is true about Goucher? Yes, this was frequently asked question. I told you that Goucher, gouch, ouch, bone pain, and you will give tissue paper. Yes, and she will crumble tissue paper appearance. Beta glucosidase deficiency or glucocerebrosidase. Yes, deficiency. Okay. In this, you know, Niemann-Pick disease, sphingomyelinase is deficient, and there is hepatosplenomegaly, foamy appearance is there. Neem soap, mnemonic बनाया था हमने, we made mnemonic. So sphingomyelinase defect in Niemann-Pick disease, foam cell in Niemann-Pick disease. Answer is A and C correct. So answer is B. Answer is B. Next question. Which of the following are true about HMP shunt? Yes, HMP shunt, no ATP produced. We have already discussed multiple times. HMP shunt, no ATP produced. The rate limiting enzyme is G6PD. Yes, and produce pentose sugar. That's why it is also called pentose phosphate pathway. And it produces NADPH, NADPH, not NADH, not O2. So this is true. This is true. Non-oxidative phase is reversible. Yes, this is repeat question. मिशन क्लास में भी हमने डिस्कस किया है डिटेल में, हर बार मैं पॉइंट आउट करता हूं. दिस इज इरिवर्सिबल ऑक्सीडेटिव फेज, रिवर्सिबल non-oxidative phase, non-oxidative phase. So this is also true. So answer is A, 1, 3 and 4. Yes, true about HMP shunt. Yes. Next question. An experiment targeting epigenetic modification, rheumatoid arthritis patient, synuclein fluid, increase expression. This is important. Increase expression. You know, acetylation of histone, what do? Acetyl group is having negative charge, histone is having positive charge. If you bind, charge is lost, DNA will relax, euchromatin formation, increased transcription. So acetylation of histone, increased transcription. Yes. And deacetylation of histone, again, condensation, decreased transcription. While methylation, DNA methylation, we know that methylation of cytosine at promoter region decreased transcription. So if you inhibit DNA methylation, there would be increased expression. Answer is B. Answer is B. Actually, C and D both are same thing they have given. Next, deficiency of which cofactor shunts 3-hydroxyquinoline to xanthorronic acid pathway? You know, normally 60 milligram of tryptophan give rise to 1 milligram of niacin. Yes, baby doll, indole ring, tryptophan, we know. Yes, this is converted to 3-hydroxyquinoline, then 3-hydroxyanthranilate, multiple step niacin. And cofactor is vitamin B6. If vitamin B6 is deficient, then this step would not occur. Yes. Yes, so this will be diverted towards xanthorronic acid. This will be diverted towards xanthorronic acid urea. Actually, this question has been asked previously in our exam. I told you. Yes, this is matching. Answer is pyridoxine. Answer is pyridoxine, vitamin B6, active form pyridoxal phosphate. Next question. Match the following. Repeat question. Tyrosine, thyroid hormone, precursor for thyroid hormone, tryptophan, fate is 60 milligram of tryptophan give rise to 1 milligram of niacin. Tryptophan is coming to serotonin, then coming to melatonin. Glycine is used in creatine, create, mnemonic was game create karo, bajana nahi hai, create karna hai. Glycine, arginine and methionine. Creatine, glycine is there, cysteine from taurine. So simply, if you know initial, you can find the answer A1, B2, C4, D3. Answer is B. Answer is B. Okay. Next, which of the, yes, this was a repeat question, just to tell you that in our class we have discussed this question. Okay, so if you have little bit about idea about xanthorronic acid urea, so you can easily find that this 3-hydroxyquinoline is a intermediate of tryptophan metabolism, and there was interruption of this metabolic pathway lead to xanthorronic acid urea and cofactor vitamin B6. Yes, these are previous year questions, just to tell you. In TCA cycle, which intermediate serves as the main substrate for fatty acid synthesis? Actually, this is in tricky question. You know, in fatty acid synthesis, we start from acetyl coenzyme. And we found that this acetyl coenzyme are transferred from mitochondria to cytosol with the help of intermediate of TCA cycle, citrate. So, you know, acetyl coenzyme bind with oxaloacetate, to form citrate. This citrate come out of the mitochondria. Now citrate is again converted to acetyl coenzyme and oxaloacetate. This acetyl coenzyme take part in fatty acid synthesis. Okay, good. So answer is A, citrate. Clear? Next question. Yes, this is a recall based question. What was the exact question? We don't know, but as I could collect true about fatty acid synthesis. In fatty acid synthesis, the first and rate limiting enzyme catalyzed by acetyl coenzyme carboxylase. Cofactor biotin. And mnemonic was carboxylase. Wherever carboxylation is there, mnemonic is ABC. कार में एक्सीलेटर होता है, ब्रेक होता है, क्लच होता है. A for ATP is used, biotin is used, CO2 is joined. So ATP is used in this process. This is true statement. While other statements are they are talking about beta oxidation of fatty acid, not fatty acid synthesis. So you can easily find out the answer this. But to complete the concept, we have to point out in beta oxidation of fatty acid what happens. First of all, fatty acid is activated. Activation of fatty acid, yes, this requires 2 ATP, and now fatty acid enter intermembranous space. Acyl coenzyme A bind with carnitine to form acyl carnitine plus coenzyme A. This is done by CPT1, which is present at outer mitochondrial membrane. Yes, CPT1 is present at outer mitochondrial membrane. Outer mitochondrial membrane, not inner mitochondrial membrane. This is false statement. Coenzyme A. Yes, when this reaction occurs, coenzyme A is produced in intermembranous space. Yes, so you can say release in cytosol, not it is released in intermembranous space. Carnitine is released in mitochondrial site. Yes, this acyl carnitine is transferred. Then acyl carnitine is going to acyl coenzyme and carnitine. Yes, this is released here. Okay. Okay, so this is true. Okay. Statement is true. Carnitine is released in mitochondrial site. So according to question, you can find the answer. What was the question? So this is beta oxidation of fatty acid. Patient undergo folate therapy. As you know, vitamin B12 and B9 both work together to convert homocysteine to methionine, and if B12 is deficient or B9 is deficient, both lead to non-classical homocystinuria. Yes, B9 and B12. We found that in this reaction, yes, methyl B12 is converted to B12. This B12 is converted back to methyl B12 with the help of methyl tetrahydrofolate. If B12 is deficient, then methyl tetrahydrofolate will not be reutilized. This is called folate trap and functional deficiency of folic acid. So this is the reason many times when patient of megaloblastic anemia is there and we give folic acid and don't give supplement of B12. Yes, B12 deficiency will persist. Megaloblastic anemia may respond, and this will lead to subacute combined degeneration of spinal cord, and these symptoms will worsen neurological symptom. So what is the reason? Yes, folate trap. So these are the recall based question. Whatever modification you have, please any other question or point you can suggest me. We will include in the main videos in detailed discussion we will have on app. Okay, thank you. Good night.